Sushil and Srinivas Kumar, yeah, Dr.
Morning.
Batina.
Morning.
Good morning.
We are on live, sir.
Welcome everyone. It's my pleasure to be moderator for this live case session. So perhaps we can go to the site and we can introduce everyone and welcome everyone for joining us for this interesting live case. Can we go to the site, please?
Yes, sir.
I'm not seeing the site. Is that? Hello, can you hear me?
Hello. Yeah. Hello. Good evening.
Hi.
Girish, can you hear us, Dr. Codley?
Hi, Girish. How are you? Yes, we can. I can hear you. Please. Do you want to introduce the team there and tell us about the case you're about to do?
Thank you. Thank you. The outside the Apollo team, Dr. Srinivas Kumar, and yourself and the other panel chairpersons and moderators. We are from Apollo Hospitals, Bangalore, Benagata Road. Today we have a multi-vessel PCI for an ISR, and we have my colleagues, Dr. Pranit, who is technicians, Ketan and Venkaya, and rest of the team. Thank you. My Dr. Pranit would introduce the case.
Hello, sir. Can you hear me?
You're a little bit soft. Can we turn up the mic a little bit, please?
Can you increase the volume from here? Hey, Brady, get me some.
Hello?
Yes, I can hear you, but you're distant. If you speak loudly, maybe it's okay, or I don't know if your mic can be turned up.
Patient is a 60-year-old male patient with diabetic and hypertensive. He presented with 6 months history of exceptional angina of class 2, which increased to class 3/4 from past 15 days. And he has a past history of angiostomy in 2019, March 2019, where that time he underwent angioplasty to both LAD and LCX. LAD with a 3x30 endeavor resolute and LCX with 10x30 endeavor resolute. And from then onward, for 1 year, he is completely asymptomatic. From then onward, he started getting symptoms. Okay, coming to the present TCG, is showing ST depression in the anterior leads, whereas echo is showing apical hypokinesia with a preserved thickness all over the heart, with an ejection fraction of around 50%, without any MR or any pericardial effusion.
Okay.
Now next the angiogram, I think.
Can you just show the angiogram, please?
Yes, sir.
Is the angiogram visible to you?
Yes.
Can we just take a moment to introduce the other panelists real quick before, unless you have to go forward, you keep going forward, but Srinivas, do you want to introduce the other co-panelists?
Yeah, I have some connection issues here. The power keeps coming. And other friends and colleagues have already joined anyway. It's Apollo meetings. Dr. Sridhar, Dr. Ramya, Dr. Rituparna Barua, Dr. Kondal, Dr. Divijat Datta, Dr. Karupaya are there. And Dr. Damodaran Reddy and Dr. Rath will also join to co-moderate along with Sushil. Go ahead for your case.
Okay.
Hello?
So I'm
Yeah.
just taking an OCT. Give me a minute, and then I'll go through the case. Ready? Mr. Bala to the left now. Side fourth page. Ready? Stop. Well, I think it's not as great as the first time, but it's okay. Okay, can we go to the diagnostics?
Can we play the diagnostic films? Just I didn't get a chance. Can we see the diagnostic
Yeah.
films?
So run slowly. This gentleman is a right dominant, right side coronary artery is normal. He had an MI, LAD, anterior, and at that time that stented is LAD and circumflex, and there's a big ramus with the superior and inferior branches. Unfortunately, now both stents have ISR. Can you go to this? Can you
Can you
play
go?
the
Is there a
diagnostic?
cranial view as well, or is just Can we just see the diagnostic film? Thank you.
Yeah. Okay. Cranial? Yes. These are audio
Okay.
corner. Cranial. Come back, please. Come back. He's got even left main osteal disease.
Okay.
The gentleman was offered vehemently a CABG, but he belongs to a community where they believe if you cut their chest, the soul will not stay inside. So he says, do anything but CABG. So we have these diagnostics. What would be your suggestions?
So yeah, obviously surgery it was the first thought, and if the patient refuses, it always often puts you in a difficult position in a case like this because he's also already had ISR. Was the last stent? It was a 3.5 in the LAD or 3.0?
Stents. The last one was
3 to 30 and 2.5 to 30. Anywhere is
330 into the LAD and 2.530 in circumflex, and they were resolute.
And he's a diabetic, poorly controlled diabetic, or
He is a well-controlled diabetic.
well-controlled diabetic. I see. Was the last intervention image guided with either IVUS or OCT or straight angio only?
Not image guided, PCI.
Okay. I mean, I think that would be one consideration as you're doing here. And it's important. I mean, a 2.5 in a proximal circ is probably small, and even a 3.0 in the LAD is probably undersized. But I think you'll have to see with the imaging. What do others on the panel think? I'm having technical issues. I can't see who's joined and who's here.
Yeah.
Are there others on the panel?
Yeah, many of them have joined. They're all not able to connect, I think.
Still inside the stem.
Damodaran, you can open your camera and talk the panelists and
good evening all. It's a nice initiative by Dr. Srinivas. Thank you for the initiative.
Do you have any comments?
Regarding this case, as Dr. Sushil mentioned, that we can go by imaging guidance so that we know the exact mechanism of this ISR.
Okay. Can we say what we planned?
Am I audible?
Yes, we can hear
audible.
you.
Please go ahead.
Yeah. The mechanism.
His circ was diffusely diseased. Okay. The plan was the circ ISR was a CTA. So we just thought first we'll open and see how good is the distal. Oh, come back. There will be a wire. Okay. We thought first we will see how big is the circumflex once we open the CTA. Can you just play that? Next.
Girish, actually, sorry to interrupt you. Keep working because the other lab, they're requesting to come immediately because there is some issue. Originally, also, we thought we'd go there and come back to you.
No
but
problem.
some which happened. We'll come back to you again. We work in peace. Then we'll see what is happening, introduce the case and see that, and then come back to you in 10 minutes. 15 minutes.
Sure, we shall do that. Thank you.
Okay. Can you switch to Apollo Secunderabad?
Give me the 3 NC balloon.
Yeah. Mute Bangalore. Let it go in a small window, but Shiva, we are with you.
Yeah,
sorry for that initial this thing. You can introduce the case. Sushil Kodali, Damodar, and others have joined. Trupti Madam, Ramya, everybody is there.
So all chairpersons, and it's a pleasure being here. And then I thank Srinivas for again giving me an opportunity to do this case. And actually, the first video which showed that the serenity and the where I was there till yesterday night. And but when Srinivas told me that you should do something on a CHF with a CRT, I immediately jumped. Although I came late night in the 1 o'clock, but I still decided that I should do a live case here because the reason being that I strongly feel that intervention cardiologists now probably should also adapt the CRT as their one of the armamentarium in daily practice. Although it's a domain of electrophysiologists, no disrespect to them, but I feel the way the heart failures incidence and the prevalence is happening in India and abroad everywhere as a result of post the LV dysfunction that is happening. I think heart failure will become bread and butter in future instead of a coronary disease. That's what is my perception. So we started CRTs way back in 2005. And we are happy to say, not arrogantly, but we are doing decent numbers, about 40 to 50 CRTs every year. So by far we have done more than 500. So I just thought, it's impossible to give the whole CRT.
Shiv, let me interrupt here. How I selected is also knowing all that. Who is good and what I have tried to search and what are the things. Who is the person who has done maximum of this? I thought I would request. And Sushil is, we do the TCT meeting together. Sushil, I wanted to mention here, whenever we were planning, all the companies would come back and request just to keep Apollo Secunderabad as a live case. I think he has done maximum number of live transmission to various other conferences. I had a challenge to talk to Medtronic or Abbott. Everybody wants him to do their live case. But this way, I thought that controversy is not there. So he has maximum experience of CRTDs, and as well as this is also not there. Thanks for accepting. Please go ahead, Shiv.
So can I ask a question real quick? So it's interesting because the interventional cardiologists doing CRTs, two questions. And is part of it is a logistical issue in that there aren't enough trained EPs to do the CRTs in India? Is that one concern, that you need more people to do it? And two, if that's going to happen, how did you learn? What is the training required? And what do you think is a learning curve for an interventional cardiologist? Because I know I would feel very uncomfortable doing it. And so, how would I learn? What would be the process?
Okay, absolutely. Your number one point is absolutely right. That's what I feel that, the electrophysiologists are not in that number, so to really cater to so much of population of the heart failures. And secondly, learning, I did go to Kuala Lumpur. Dr. Razali was the mentor. He really moderated me in Kuala. It is one of the best centers in Asia, I believe. And I was there for a very short time, but really he motivated me, and I felt overall picking up CRT is not a very big deal. It's only just an inclination. I think if you are motivated, definitely it can be done easily. Because first, majority of the steps we often do in dual chamber pacemaker and other things. So going straight to the case, because I know I've got a very short time, I have to show you what are the critical steps. So I'll request my colleague, Dr. Samir, to introduce the case, and then we'll show you what exactly so far we have done.
Thank you, sir, and good afternoon all. I'll just give a brief clinical database of this case. This gentleman is 55 years old. Male.
Samir, it's the other way around. It's upside down. Can you show it?
We are able to see it right.
Okay, fine. Okay. For here, it's a mirror image for us. Sorry.
Okay, fine. So he's a 55 years old male who is diabetic, hypertensive. His known case of dilated cardiomyopathy with severe LV dysfunction is EF was 25%, diagnosed 4 years ago, and he was on guideline-directed medical therapy with NYHA class 3 and 4. He had history of recurrent hospitalization since then, but was not willing for any device implantation. But this time he presented with hemodynamically unstable ventricular tachycardia, which was DC cardioverted with 200. His echo showed EF of 25% dilated right atrial. This was his presentation ECG. The left ECG showing a ventricular tachycardia with which he presented was cardioverted, and baseline ECG we can find that there is a broad QRS complex which is measuring QRS duration of 151, and it is suggestive of intraventricular conduction delay. So with this, I hand over the case to sir.
Okay. Thanks, Samir. And then coming back to the things, I quickly show that, what are the steps so far we have done. initially did a TPI this, and because we need to do a TPI as a landmark for any coronary sinus cannulation, then we take, these are the two important views we always suggest, the 10 or 30, 10-35 cranial and 20-35 cranial. That is the LAO 10 and LAO 20 with cranial 35. And of course, the last is plain LAO 30 views, because these are the three different, go back 1 second. These are the views which actually shows us in the levo phase of angiogram where the coronary sinus is and how to cannulate the coronary sinus. And the best part I would always say is, don't pick up the coronary sinus like that, but always see the bony landmarks and your TPI. That gives you a simple, very easy step to get into the coronary sinus, because I feel the whole process of CRT is just cannulating coronary sinus. Once you cannulate, most of the steps are then relatively easy, although we can find out the problem at any time. So going straight now, first we do the venogram of the left hand, and then axillary or subclavian, whichever you're comfortable to. But once you know the vein structure, then you do a 3 punctures. Next. So this is how we do 3 punctures. We did all the 3 punctures, and after that we do a RV lead placement first, because again it protects you. And once the RV is there, then we go for the LV. Okay, this is where I reach there. Next, please. Next. This is the LV sheath. I took a St. Jude's 115 angle sheath, and then you can see first attempt. I'm not like maybe lucky, but first attempt you're already there. And the way I used it is that just because of the TPI lead and the landmark spine I've seen, and we are through that. So there we are. I'm going live now. I've taken that wire. I'm taking the PDCA wire. There was and usually you can go to the lateral vein, whichever it is. Either you can go anterior vein, which actually runs to the LAD, or sometimes you can go into the lateral vein, whether it's the anterolateral or posterolateral veins, which again is different. You only land. The important thing is, phrenic now actually runs.
It's okay. Continue. What happened? There's no problem. Little echoing is there, but go ahead.
Did we lose the site? Looks like we've lost the site, Srinivas. Should we go back to the original
Hello?
case? Yeah, should we go back to the original?
Wash your hand. Don't make chip here.
Yes, sir.
Yeah, are we there with Secunderabad? What happened?
Yes, sir.
There's a problem?
We lost the connection, sir. 30 seconds.
Hey, are you recording? Show the distal vessel. Are you recording? I'm stem based. Show me a little. Right, show on the option. It's okay, good. Should we have taken a little?
Should we go back to the first case, Srinivas?
Yeah. Please connect Bangalore back. Bangalore, I hear Girish talking.
Yeah, can you hear us?
Yes.
Okay, we are at a crucial juncture. Give us 5 minutes. 10, 12, 14, 16. Come back. Okay, so we have to decide to address LAD, circumflex, 18.
You don't see the video. Can we see the video, please, from Dr. Garrett?
Go 1820.
You're not able to see the Bangalore video, tech team?
Go 18.
You're hearing his voice, not getting the video.
Can you show the screen, please?
We'll show the diagnostic shoot which is there in presentation.
Is the technical team on, Srinivas? Are they there?
Sorry?
Is the technical team there? Can they hear you? Can we see the video?
Yeah, they are, but they're, I think...
yeah, working out background. Just give us
initially, the first few minutes yesterday also it happened little.
20.
Hey, Ajay.
Hey guys.
Good evening. Morning, Ajay.
Morning. How are you?
Yeah, trying to figure out this morning glitches of live cases. Starting it has some challenge. Now we are able to come back.
Now we're back. We're back to the other case.
So are we on screen? Who's going to speak?
Srinivas, you take the lead here.
Yeah. Hello, Shiv. Are you able to? He's muted. Shiv Kumar is muted from Secunderabad. Keep the mic on so that he'll speak. We are able to see his video now.
Other wire.
Keep that Santosh Kumar feed coming from Secunderabad. Mic is muted. Unmute that so that we'll hear Shiv.
For the injection.
Girish voice is coming and Secunderabad Shiv's video is coming.
It's a nice cocktail.
Sorry about that. We are just trying to figure out, this being the first of today. Yesterday also, the first cases had challenged, then it went okay. Hello? Shiv Kumar, can you hear us?
I don't think so.
I know. It was to come back. It will come here.
Actually, switching on from one to other is becoming challenging in Zoom platform.
Okay. Right. Let's crush it. You know, what is this wire? Yeah. Come here. Do me a favor. Go. 16, 18. Come back. 16, 18, 20. 20, 22. Come back. Hey, LED ACT, please. 18, 20. 18, very sham. 20, 22. Come back. Slip out and up. 18, 20, 22. Hey, come back. Slowly you go. Slowly. 1, 2, 3, 4, 6, 8, 10, 18, 20. Come back. I think it's open well. Okay. See, I want a 3.5 cutting balloon. Regular balloon. Come back. Okay, let's crack. Go. 18, 20. Come back. Let's crush the stent, please come. Hello, Cordon. Stay here. Where is the other guy? 16, 18, 20. Please zoom down.
Hello, Kiran. This is not done yet. Yeah, neither we are able to see them properly and hear them. We are doing a mixture of both. If there's a problem, we will have to
Zoom is creating
talk, then we can. Yeah.
I can do why don't I do my talk while they try and figure this out?
Yeah, that's what I'm saying. One minute will give them a chance. Now Secunderabad video is getting projected. Can you get audio of Secunderabad once? But Santosh Kumar audio feed from Secunderabad, the mic is muted.
Sir, system. Show me double length. Where is this one? Okay. Now I want a fresh wire to re-enter. Okay.
Here everything is old, right?
Okay, give me that shampoo. Hey, what shampoo itala illi? Where is it? Huh? Adinda? Medium. Light.
Hello.
Yeah, Srinath.
Yeah, Anil.
You are able to hear me?
Yeah, now we are.
I was calling Ramesh. He's not picking up the call. I think.
Yeah, I think now we can see you and hear you.
Cool.
In between, lost some connection.
I think we're still hearing Girish. That's the problem.
Lydia. Keep it aside. Show me.
Kiran, can you mute Bangalore now? We are able to see audio and video of Secunderabad. We'll give 5 minutes here, then go there.
Yes, sir. Yes, sir. Just inform them, sir. Yeah.
Shiva, can you hear us now?
Yeah, I can hear you now.
Yeah, we can hear you as well. You can continue and show what you're doing.
Okay. Yeah, because in between I lost completely, so I didn't know where I was.
Sir?
So what are like? Can I continue?
Yeah.
Okay. So when I tried to put a lead inside, obviously the lead was because the particular lead has got a lot of bend. So sometimes it goes and hits the sinus branch. The whole thing came out. So everything came out of the coronary sinus. So again, I had to recanalize coronary sinus with a wire back. So now I'm taking a lead.
Too much. Come to which other view? Come to this moment.
Okay, I think now you can work in peace, reposition the lead, everything, and we'll get back to you. Is that okay?
Sure.
We'll go to Bangalore, connect to Bangalore, Girish. We'll see briefly what he's done and then go to Sushil's talk. Can you connect to audio and video both of Bangalore, Apollo?
Yes, sir. Give us a second.
Yeah. The way to do is just keep them in the small window and unmute them as and when required.
Sorry?
Sorry, I am talking to the other team. Go ahead, Sushil. Secunderabad. You can mute Secunderabad now. Thanks, Ajay, for joining early. Sorry for this confusion.
I think you're on mute, Ajay.
Sorry, it was my mistake, not yours.
No, we're happy that you joined. Not your mistake.
No, me too.
Should I just do my talk because the video is not coming through? Maybe we come back once they figure out the video situation.
Okay. Kiran, can you get Bangalore for some time, or you're not able to do? Then we'll go to Sushil's talk.
No, sir. Another minute, sir. It's almost done, sir.
212. Kuro. Are we audible and visible from Bangalore?
Yeah, we are able to hear you, Girish, but you're not seeing your video yet.
Okay.
We're trying to figure out.
Sure. Okay. So anyway, let me run through the commentary. Here we have trifurcation lesion. Both the stents in the proximal LAD and proximal SEP are re-stenosed, and there's a significant sized ramus which has both inferior and superior divisions, and at the bifurcation, both divisions have osteoarthritis.
Now they will be back, sir.
Sorry?
They will log again, sir.
We lost everything.
As we lost the video, I just asked them to log off and log in, sir.
Yes, why don't I do my talk and then we'll come back. Maybe they'll have my talk will be 10 minutes.
Okay, sir.
Okay. Give rights to Sushil to share the screen.
Oh no, they're connecting now. Maybe they're there.
Yeah, now they're there.
They're muted.
What stent you want? Yeah.
Is 10 minutes okay?
Girish, what are the patient's hemodynamics right now?
Yeah, hemodynamics are very good. Heart rate 96 and BP 130/75. A touch of noradrenaline infusion. Preserved AV function, it's about 50%. He's behaving very well.
Can we take is it okay to take a pause for a second just from a teaching perspective to discuss the case?
Why not?
It would be helpful. Dr. Kirtane, Ajay is on the line as well. Can you just show the first film? Ajay, briefly, this is a young guy, diabetic, who had a non-STEMI several months ago, and they stented the LAD and circ. He now presents with unstable angina again, and he has a complete occlusion of the circ critical restenosis of the LAD, and the patient absolutely refuses cabbage because he feels if he opens the chest, essentially some sort of cultural religious concerns, and so they're left with only percutaneous options. And I think it's worth the discussion here with this extent of disease. So normal LV function, EF is 60% still, but unstable.
And what kind of stents were put in before?
Resolute, 3.0 in the LAD and 2.5 in the circ.
I mean, that's incredible.
Yeah. One, what are the options? Two, if you are doing this case, do you need? Is this a case that you would consider hemodynamic support? LV functions normal. We don't have an EDP, but is hemodynamic support necessary in a scenario like this?
You know, for me, with just ISR and you know, relatively straightforward disease and a abnormal ventricle, I don't think I would lean towards hemodynamic support. I would use the EDP or a right heart cath just to prove that the numbers are fine before starting. But as far as the options for treatment, I mean, this is diffuse ISR that we used to see with bare metal stents. So there's clearly a stent failure mechanism here that needs to be understood, especially with such early restenosis. So it's going to be you'll be able to get through the case, but the long-term outcomes are not going to be great.
And then, Girish, you want to discuss your? Oh, sorry, go ahead.
He has done the OCT to see what type of ISR he had. Did we run those OCT pictures, Girish? Do you have time to run them?
And in the initial plan, you opened up the circ, Girish, right? To start, you opened up the circ, and then you did OCT, correct?
Yes.
Next.
And that was nice and carefully done with the microcatheter, because if you get behind a stent strut, you can make the case very, very difficult quickly. So the way that was redirected was great.
Yeah, we use a BMW to angle down and then took a pilot 200, and there is no sufficient support, so we have to anchor. Next. The guide, the microcatheter wouldn't go down. Next. Yeah, we now with the balloon inflated in the LAD.
No, we're seeing the OCT. We're not seeing the angio. Oh, there we go. Now we see the angio again. Okay, you ballooned.
Yeah.
Okay.
With that support, we could really take it down. Next. And then next. OCT.
So that anchoring technique is an important technique to know how to do. Really helps.
Yeah. And then we did
can I ask a question here? So Ajay raised the point of, you know, especially when you have stents all the way back, how do you ensure that you're not underneath the strut of the circumflex? I think that'd be important sort of learning point from this case. So how do you verify that you're in the lumen there, not behind the strut? I mean,
you know, it's difficult, but then there was an ISR even proximal to the stent, and I thought, you know, there is a tissue overgrowing the stent. So, and secondly, we used slightly knuckled wire to reach through the stent, and then took out the wire, just push the microcatheter to the edge that it would go, and then took a CT over, hoping that, you know, it would be facing not underneath but somewhere inside. Would you have any other suggestions?
No, I think those are all great techniques. It's also one of the reasons why it's not a wire you hear a lot about now, but miracle wires, which are very dark and allow you to see where they are in relation to the stent, can be sometimes useful. And then the final way is with the OCT, you'll be able to see clearly what's going on afterwards. But sometimes that may be too late, because in order to deliver the OCT, you're going to have to balloon first.
Yeah, circumflex OCT. Can you show OCT? This is the full doc, you know. I couldn't take the wire any down, the OCT catheter. The reason is, you know, it may dissect if I go further down. And I thought the disease is in the stented segment. Over this disease down, I will do a DED. So I didn't need that so much imaging down. And when you image the stent, you can have a look at it. It's a diffuse ISR, undersized, probably the stent size.
Yeah, one of the challenges with this case, and this is sometimes where IVUS is favored, is that if you don't have a segment of normal EEL to EEL, you won't necessarily know what the vessel size is via OCT. The problem with IVUS and very diffuse disease, though, is you'll never see where your landing zone is and that kind of thing. And so sometimes it just becomes hard to estimate. But for a young person like this, you would imagine this is going to be at least 3.0 in terms of the vessel size, almost out to where that bifurcation of the other OM is.
So, I agree. Are you able to see the OCT?
Yes,
yeah,
we
the
can see
stent
OCT.
totally looks undersized. I mean, it's like a 225 or 2.5 down there.
And then show them the now angiograms, if you don't mind. Go to the angio. Yes. How do you approach this now? My call was, let me do a DB to this. We took a 3 into 30, 40 DB to the circumflex stent because, ISR, however much I treat using another stent into this diffusely deceased, higher chance of stenosis compared to putting a stent into the ramus. I mean, that is my thought process. So we just did the DEB and then addressed both the branches, divisions of ramus. Go next.
That makes sense.
Before doing DED, do you prepare in diffuse disease? Is it worth doing cutting balloon or anything like that? Or you go straight with the DED?
We didn't take a 3 mm cutting balloon. Honestly, we took a 2.5 into 10 cutting balloon. Can you just show me a sec? Wait a second. No, after this. No, after imaging. Next. This we did a OCT to confirm whether it's cracked. Go forward. And then we came down to LOD to address this, to understand. Again, the disease was the same. Can we show the LOD OCT to them?
Yeah, that looks undersized as well.
And that was a 3.0 to start, I think.
Yeah, LOD OCT. Come back. Yeah, LOD OCT you can see. This is very bit of
Impressive. Yeah.
significantly undersized.
So is anything going to work in this gentleman? I think this is both stents diffuse ISR, right?
We're just going to pay for him, but fix for the acute result until he makes up his mind for another CABG. I mean, a CABG basically.
This is only 3 months ago?
No.
Done in March 2019.
1 year.
Oh, okay.
1 year.
And he's having symptoms from past 1 year.
So maybe early ISR. Okay. And then the angio. And then we decided once we imaged the LOD, we knew it was undersized again a diffuse disease. We came back to the circumflex and did a cutting balloon. We took a 2.5, went at about 14, 16. And then we did a 3A predilation again with the help of NC balloon. And we took a devoluting balloon 3 into 40. And next. We ran another OCT. Can we just run the OCT now? Yeah, LC exposed OCT. It looks slightly better, but not great there. It is a uniform dilation of the lumen. The tissue, whereas the ISR, it's not very dry and hard. It seemed pretty wet. It is yielded and given a lumen. Next. And then we thought we will go to the next, go to the fluoro.
Can we see the angio again? Yeah.
Show the angiogram. Okay. So next. Then we went to the LOD. Pre-dilated it with a 3.5 balloon. Next. Sorry, this is the first cutting balloon we used, 3 into 10 again, to get the maximum diameter that we can achieve. Next. And now we wired both the branches of ramus. Show next. About 7 French system. And after pre-dilating both the branches, next, we thought we should do a decay crush to the early diagonal ramus into LED. Next. Yes, diffuseness to the entire disease. Next. Okay. And then we came back and crushed that stent. Next. Go. Next. This is a 3.5 NC balloon. Next.
And you did not re-stent the LED, right?
No, we are just recrossing the struts now.
Right.
Into the LED. And we are into that. This is where we are.
Can I ask a question? With so much restenosis in the LED and the circumflex, what did you think about just doing a drug-eluting balloon in the ramus alone?
Would we, preserve the LV function? Would we leave behind the severely ischemic circumflex and the LED?
No. Meaning DEB to the circ, DEB to the LED, and DEB to the ramus without putting in more metal.
I get it, but it's a very proximal area, and I still feel we change the platform, both the stent as well as the drug, and since it's a proximal and future addressing of the branches will be easy with a bypass. And for a tight lesion, I will show you, the lesion did not yield even at 12 atmosphere initially, but subsequently it yielded. I thought stent may be a better option, but I'm not sure. What do you think?
Yeah.
No,
well,
no
the challenge is
That's
even
right.
though the platform is different, the ultimate mechanism is a limus, so it's going to be somewhat similar. So my sense would be I probably would have tried balloon only and not put more metal, because it's hard to blame on the specific stent type when you have that diffuse restenosis in two vessels. But there's no right answer to this case.
Yeah, I agree with you. So now there's a 2 mm balloon and there's a 3.5 balloon in LED. We're going to crush and do the first crush.
So I just want to clarify that what you did here. So you protruded the stent out from the ramus, and then you crushed it, then you recrossed it, and now you're ballooning it. But you did not put a new stent in the LED, correct?
Not yet. I'll crush it. I'll do a kissing now and then for one kiss. This being my practice, it allows the re-entry much easily.
But do we need to put another stent in the LED? I guess the question is at this point, if you crush it there and balloon it.
I am going to put, because there is an osteal left main disease too.
Okay.
Okay, go. 10, LCX, 18, 20, ramus 20, come back, LED.
Whenever your time is up, you can start your lecture as they keep continuing.
We'll skip. Why don't we stay for the end of this, Jonas, and then I'll come back later and do it.
Thank you.
Okay, no problem.
Because Ajay's here, he can start once this finishes.
Okay, good. Give me a stent into the LED. Do you all agree we should stent the left main to LED? Show the first diagnostic injection, elevate cranium.
So part of the challenge is that with OCT, you really can't see the osteal left main, right?
Sure. No, we can. Can you just show osteal left main? You're
So
able to see this.
Can you see the left main, or is it already?
LED injection, if you don't mind. LED injection, not soak.
Ajay, people say that by using a guide extension, such as putting it there with 7 French, sometimes you can image osteum of left main. Did you try that?
Yeah, not. I personally have not. I think you can. It's just a little harder. The other thing that we like to do with the real-time IVUS is to actually position it at the ostium and cine, and so then you know exactly where the ostium is, so that allows you to position it. But I'm sure there will be emerging ways to do it with OCT. But I just haven't had the greatest experience doing it that way.
I guess that's the challenge. Like in a case like this, what would everybody prefer, OCT over IVUS, or would you say IVUS, or how do you approach this? What does one provide over the other? Is that from a guiding perspective?
Yeah, it's tough. I think that the left main part will be better with IVUS, The other thing that IVUS will show you more accurately to some extent is exactly how big the vessel is. The challenge is with so much diffuse disease, you're not going to be able to necessarily get a disease-free segment distally, so that'll be hard to sort out. And what's nice is that all of these measurements are much easier, I think, using OCT than with IVUS.
Mm-hmm. So
And
for
instant
people that don't do a
hysteresis
lot of
also, these
cases, do you think OCT is easier to learn to start or IVUS?
I think if you're starting from scratch right now, especially because of the software, OCT is easier. I also would say though that that you need to know how to size appropriately, because the OCT is so lumen focused, you're going to be smaller than by doing IVUS. So you really have to make the effort to truly go EEL to EEL, so that you size adequately. Otherwise, it may look great, but you may be completely undersized.
Bifurcation view, what they're showing?
Yeah.
Okay. Center it. Show me.
So that's nice. Proximal strut, it looks like, crossing.
That's okay. Should we go in a bit, or you are happy with it? Hey, play the fluoro please to them screen. Okay. Are you happy with the osteal positioning?
I might go
That is very
in like
important
half a
for everybody.
millimeter.
Half a millimeter in?
This is one where I tell the fellow to pretend to move it forward half a millimeter.
But don't move it.
But it's very important to check in the cranial view, the osteal positioning. That's what Giddy should do.
Yeah.
And that's good, I guess.
What stent is this?
Expedition. Go.
Yeah. So with the Xience, it's a mid marker. So your stent is going to be at the mid marker there.
Yeah.
So that's important to know, because other stent types, it's in a little bit from there.
3.5 and 4.5 balloons.
For osteal placement, that helps Ajay, I think, because stent starts with the marker, so you're
Yeah,
more
exactly.
confident.
Wait.
Exactly.
Go.
What you're doing is very nice here. So carefully disengaging the guide, because, you know, in the Excel series of IVUS of this left main, a significant proportion of stents were distorted at the origin because of the guide smashing in and out at that point. So you have to take your time and do it carefully.
The circ wire is behind that stent, right? So
that's what is actually pulling the guide in.
Yeah.
I'm just going to get that out now, and I would rewire it once I get a good post dilation in this. Give me a 3.5 and 4. I will need another stent in the distal part of the stent because 48 was not long enough to cover the stent edge. Okay, give me 3.5 and 4.5.
But the point of the guide distorting the stent is an important one. I mean, I think that can happen very easily, and then, you know, but I guess you can generally manage it by going back with the balloon after, and that's part of the reason for going back with the balloon after in terms of post dilating the ostium as well, right?
Yeah, I think the first movement of the stent balloon should be distal rather than proximal to release it from the stents. In that way, you do not deform much of the ostium of the stent. Okay, calling it.
Preferable to have the guide movements over the balloon rather than moving it when the balloon is
20, 22, 24. Come back. When the guide is touching the proximal part of the stent, it's always better to move the balloon first down and then get it back. 20, 22. It looks a very soft ISR. The balloon expanding really well. So hopefully, sizing will keep this appropriate size.
What size balloon is this?
3.5, 12. Come back. Go. 2022. Okay. 4.5. Go 18, 20, 22. Come back. 40, 20, 22, 24. Okay, 4.5. Come back. 4.5. 20, 22. Okay. And I always engage the guide on the before I deflate the balloon so that your next device, whether it is another balloon, a stent, or even the wire, doesn't catch the stent struts at the ostium. Okay. 4.5. What is the last ACT?
So are you going to rewire the Ramus or Circ and KISS again? Or are you going to do it for both, or just?
I'm going to do the pot and then I recross.
And then are you going to KISS both the Ramus as well as the Circ?
Yes, no, not the Circ. I'm going to do the KISS into Ramus to LID.
And so you're not going to open up the Circ struts, though. You're just going to leave.
I may just open at the ostium, but do you all agree? Should I defend the stent so much more now with all this OSR issues?
I don't know. Ajay, what do you think?
Dealer's choice, I think.
Yeah.
Oh, sure. What would you do, Dr. Cuddly? Okay, go. 10, 12. 10, 12.
Does the fact that the Circ occluded, his presentation was with an occluded Circ?
10, 12. Okay.
Srinivas Rajay, what do you think? The fact that it presented with an occluded Circ, would that change how you approach the KISS or not, or others on the
I would do everything I can to maximize areas. This is not one where you know, it's a de novo where you just leave it if the flow is okay.
Oh, there's still in there. Could I go? 14, 18. There's a 4.5 balloon. We will dilate the ostium of this stent. The other wire out a little. Okay. Go. 14, 16, 18, 20. Okay. There is still a little more stent, I guess. So show me stent boost. Go AP, go AP, go AP, go further AP. Just plain AP. Okay, stent boost. Okay, I'm in the ostium, go. 14, 16, 18. Okay, now the ostium is flared. We'll recross the wire now once the guide goes in. Yes. This clearly shows that my guide is sitting inside. So, they gave me a G. Okay.
So we don't have a lot more time, but what is the planned follow-up? So this gentleman had aggressive ISR about a year and a half out, sounds like, from symptoms. How do you follow this patient? Do you do a stress test? Do you do a repeat angio? How do you approach this?
Asking me?
Sure, yes.
Yeah. I think, it's very aggressive medical management, close supervision, but if he eventually develops, I would spend time enough to do convincing for a surgery. I think that's what I'm going to invest my time in. Give me a word.
Yeah.
I think, Ajay, for the sake of viewers, for ISR, as you understand, if you image it and any particular point of stent is underexpanded, you dilate it and pre-treat it, and then probably end up with a DEB or something. But it's diffuse atherosclerosis like this. Wouldn't you prefer putting another layer of stent? Obviously, you would avoid another layer of stent, but diffuse instant restenosis is where there's a lot of material. What is your approach?
Yeah, it's going to be hard to treat definitively with a DEB alone. The issue, though, is that the way I think about these patients is not just the time they come in, but they're going to have multiple problems. It's rare that they're going to be fine the first time. So I don't think it's wrong to try with a DEB before putting a second layer in, because the next time they come, then you can put the second layer in. Once you start putting more layers, you start limiting your options. That's just our philosophy as a whole. And we don't even have DEB. So maybe it's because you have better experience with DEB than we do, that it tends not to work, that the stent makes sense. But I guess that's how I would think of it.
Recently, there was a review in CCI saying that after whatever mechanisms you worked, the residual plaque is still occupying more than 50% of the area. Then that's where you need to prefer the regulating stent.
Yeah, I mean, the balloon only is not going to work very well under those circumstances, because it's hard to get a big area.
Yes. Girish, I'm worried we need to go to Secunderabad before we close. Now the plan is you'll rewire the LCX and do a kiss, and then see what is the plan now?
The plan would be to just do the bifurcation kissing here, and maybe after that I would, should I open the struts to the circ or leave it? What is the consensus among the panelists?
Ajay felt you have to do it.
I would open it because I think that presented with an occluded circ. It's not, and we didn't put another layer. I think the likelihood of another 100% occlusion is reasonable, and I would preserve access as much as possible. But I don't think there's a right answer. What do others think?
2.5 balloon, 2.5 center dot balloon. 2 mm center dot.
Show the live fluoro, please.
Live fluoro?
No. We are able to see you, but the fluoro is freezed.
What do you think? Stent circus, come to a lower caudal, let them show. There's a very wide angle. Can we go to lower caudal? Do you think it's really necessary now to tap that into the circ? Ostium looks pretty wide there. Do I need to run a OCT there?
The narrowing looks after the ostium, you mean? Minimal under, after the LCX ostium, it looks narrow. That's what you're saying?
Yeah, but the ostium looks pretty broad. So I can probably do a DEB again. The same balloon. I'll go in. I've already done a regulating balloon. What do you think?
Yeah, if you say image and if you feel the area is okay, then probably you can leave it. But sometimes it could be challenging taking the OCT through the struts now.
True, I agree. But we will
think after imaging, then you can decide whether you're going to work there or not. Otherwise, you will leave there with the regulating balloon dilatation. That's what is the case.
I think that is what I may consider doing. Give me the 2.5 balloon when I'm ready.
I think it's also important to just check the distal extents of the stents in the LAD and ramus so that there's no problem there. And then probably end up doing a final thing for LCX ostium. I think with this, any final comments on this case, Ajay? We'll go on to Secunderabad for a few minutes and then go to your talk.
No, I mean, great job on a tough case.
Thank you.
Yeah, Shiv, we are back with you.
Okay, it seems like that, I'll have to really work for a long time more. I'll show you the steps, what has happened, because up to this we have seen, and the lead was not going. I tried various techniques, but lead was not going there. Next, please.
What are they doing?
So I rewired again, and 2-3 times I had to recannulate the coronary sinus. Again rewired and took this wire.
Give me 2.5 NC balloon or 2.5 NC balloon. Go.
Okay. So
mute Bangalore, please. Yeah, go ahead.
Okay. So again, really couldn't go through that despite all manuals. The just lead refuses to go, and there was something like a narrowing at in the body of the coronary sinus, and it was not allowing the lead to go at any cost. So then reluctantly I thought, okay, let me check the middle cardiac vein, and then I did a middle cardiac vein. Next, please. So this is what it is. Then we came down and then went into a middle cardiac vein. Middle cardiac vein is also reasonably okay if you can go laterally higher up, and that's what I did here. So went up to that place, please. Then took the lead there. Lead went on easily, but this is what is the worst thing for any CRT is to have a diaphragmatic pacing. So although we were having a considerably a good thresholds, but unfortunately even at 1 volt it was next please. It was continuously doing a diaphragmatic pacing, so which cannot be accepted. So then we had no choice. Then again came out. Next, please. So I rewired again, leaving the wire in the middle cardiac vein. I rewired again into the coronary sinus and went into the lateral branch, thinking this angulation might help. But again, that also really didn't, despite trying, the lead didn't go. So what we did is next, I took a 3x9 balloon because I thought, there is a flap probably while during manipulating the coronary sinus sheath. It had a little dissection because that's where it was obstructing. So I did a balloon dilatation there. And after balloon dilation, next please. You can, before this. Balloon, okay, there was one shot which was good indentation was there. So that's where we stand now. But the thing is, I had to, because it's a coronary sinus, and then again going into that, so I have to leave about 5-10 minutes time before I can start with again going.
Ajay, I think as you said, we'll start a little early. Are you ready for your talk?
Yeah. Let me just change the lighting. Hold on.
Okay, please.
Yeah, perfect. Hold on. Let's see this again. Perfect.
Yeah, we are able to see your slides.
Okay, great. Okay, so I'll start. Thanks so much for having me. I was asked by Srinivas to present what are the 10 commandments of CHIP, and the challenge with commandments is it sounds like it's a religious thing from above, and it's certainly not that, but just some ideas that I've had over the years of working through these cases and talking to these patients. So with that, I'll go ahead and get started here. Disclosure conflicts. So I'll start one by one and go through some data and examples. And I would start by covering areas of imaging, covering areas of physiology, hemodynamic support, just how you should think about these cases as a whole. And hopefully through this talk, you'll get some learning in that regard. So first, I'll start off by saying I do think physiology is really important to understand and to use when deciding to revascularize or not. Some people think that there's no role for physiology in CHIP cases, and I would strongly argue against that. The reason is that we know that our eyes can sometimes deceive us. And this is just an example of a slide shared by Martin Thomas, where these lines look curved, but in reality, because of the dots and the colors, they actually are straight. And so the same principle can happen when we think a lesion needs to be treated, but yet maybe it's not hemodynamically significant, and physiology can be the arbiter between those two things. So this is just an example of a patient that I treated, and I remember calling for the rotoblator when I saw this initial angiogram. And then I remembered that the reason the patient was there was because they had normal stress testing and abnormal CT showing calcium, and was very, very concerned. And that's why we were doing the diagnostic catheterization. So rather than just treat it in an asymptomatic patient, I actually did FFR way down in the PDA, and it was normal. And it turns out that this patient actually ended up 2 weeks later having a retinal bleed. And had I stented this, probably would have lost sight and vision in that eye. So this is just a remarkable case in my mind that sears into my memory that we need to treat things for the right reason, and the physiology can help us determine or help arbitrate that. So generally speaking, when we take stable patients, not acute coronary syndrome patients, which is a different bag, what we're trying to optimize is taking the clinical scenario, with the non-invasive testing, such as stress testing or CTA, and then correlate those two. And the angiogram further allows us to correlate to make a decision whether to treat. And all these three things go together. So symptoms, stress testing or CTA, and then the coronary angiography. Now, if those things all agree, you don't have to do physiology. If the patient has symptoms and a severe lesion and a positive stress test, go ahead and treat it. The reason to do physiology is when the data is either missing, so you don't have a non-invasive test, or you have a very, very fuzzy history, or there's discordance between the two. For instance, somebody without a lot of symptoms, but a severe lesion like the one I showed you. And then the physiology can help determine what to do. So you don't have to do it in every case, but you can be selective when you do it based upon these probabilities. I think it's also really important to remember that it's not a specific number that gets you to treat. Just because the FFR is 0.81 doesn't mean you for sure should leave it alone, or the IFR is 0.90. You have to think about this as a continuous marker of risk. And the lower the number is, the higher the risk is. So for a patient, if they have diffuse disease and they don't have a lot of symptoms and your IFR is 0.87, that's a lot different than that same patient with an IFR of 0.6. in whom the risk is going to be a lot higher for leaving it alone. So I think that's an important thing. And for our trainees, it's hard to get people out of the mindset of just not treating the number, but to think about it as a continuum. And the other thing to remember is that sometimes physiology will show you that it's not just you're leaving things alone. They'll show you that there's disease that angiographically perhaps doesn't look severe, but yet physiology can be severe, particularly in the LED distribution. So it really can help to make things more objective when you come to the cath lab. In addition to that, you can use it to plan your PCI approach. And this is just an example of a case that we did live for TCT, a lot of diffuse disease. There's disease in the second marginal, the first marginal, the bifurcation, and then the left main. And what we ended up doing in this particular case by doing a pullback is determining that we did not have to use 2 stents at this bifurcation. In fact, we didn't even have to stent the bifurcation because there was only a pressure loss of 0.03 across that. Most of the loss was in this area, in the left main itself, and obviously down here, which was not the pullback here. So we treated this, we treated this, we treated the left main, and we were able to avoid having to stent over that bifurcation. So it can be helpful. Now, what about other strategic approaches? And this is where we'll move to imaging. And there are going to be many uses of imaging in chip cases. We feel that it's kind of mandatory to do some sort of imaging in chip cases. And so for left main bifurcations, it can be really useful in terms of planning the strategy. And we just saw an example of that in the live case before. One reason for this is the left main is notoriously deceptive from an angiographic standpoint. And what one can appreciate from this slide is there are cases where the left main looks severe and there's no plaque. There are other cases where the left main doesn't look bad at all and there is severe plaque. And so this imaging can help determine if this prognostically important lesion, the left main, ought to be treated or not. But beyond that, it can also look at the distribution of plaque and can help you determine what strategy to use. We often find that when we think the disease is only at the ostium of the LAD, it frequently extends back into the left main. And the circumflex, if you image it and there's not a lot of plaque there, you'll favor a 1-stent strategy over a 2-stent strategy, which reduces the risk of restenosis, certainly reduces the time of the procedure, and if the patient does come back, gives you further options. After you've treated the left main, you have to go back and image to optimize because this is a lesion subset that typically should be favored by surgery. But if we're going to do PCI, we need to do it well. And so we need to expand our stents. And then we talked about this during the live case, that there can be acute stent deformation seen on IVUS. This was in the Accc trial. 7% of patients had this stent deformation that was associated with an increased incidence of adverse outcomes over the follow-up period. Now, beyond left main and bifurcations, what about calcium? Well, we can use imaging to determine how to treat the calcium. Should we use a balloon? Should we use atherectomy? What should we do? And the increasing awareness that what you're trying to look for and get is a fracture, which then allows the balloon and the stent to expand, is the way to getting the best outcomes. And we've actually developed an OCT-based scoring system that was published that looks at the thickness of calcium, the arc of calcium, and the length of calcium. And if all those things are bad, unfavorable, more thick, more angle, more length, then that would favor an atherectomy-based approach. IVL may be able to modify this to some extent as well, but that still remains to be determined. Now, beyond that, we talked in the last case about stent failure, and we want to image to determine why the stents failed. The reason for that is that it's common to have neointimal hyperplasia, like the case we saw before, but it's also extremely common nowadays, especially, to see underexpansion. And you're going to treat either of those things differently. You're not going to treat underexpansion with a drug-eluting balloon only. You have to expand the stent first. And similarly, if it's just neointimal hyperplasia, then maybe you need more effective therapy and you don't have to further expand the stent or overstretch the stent. So the reason to image for stent failures is I think it's also an empiric thing. It's the current stents in PCI are safer than ever. So if PCI fails, we got to figure out why it failed. Not only for our own sake and knowledge, like in the patient before, why did this happen? We needed to kind of know for our patient's sake. And then once we see what we find, we will treat differently based upon the mechanism of the stent failure. Finally, after we do our work, we really need to optimize our results because, as I said, these patients can come back frequently, and we want to make sure that the likelihood of that is as low as possible. Beyond stent failure, I would say that for stent optimization in complex disease, we want to use imaging because this is where the data supports the use of imaging. If you have a type A lesion in a 4.0 RCA, it's going to be very hard to demonstrate that you're going to get a better result if you image versus not imaging. But when the disease is more complicated, more diffuse, smaller vessels, calcium, bifurcations, that's where we may be able to see a difference. And that's exactly what's been shown by the data. This is data from the ultimate trial. This is the primary endpoint, but certainly the events have stayed separated with later term follow-up, demonstrating that IVUS-guided PCI was superior to angiography-guided PCI. As you know, the Illuminate 4 trial has just completed enrollment, and so this is more data that we're eager to get the answer to. Now, how do we do it? I told you before about how to do it with OCT. It's much easier. You measure EEL to EEL. You can then determine your stent size accordingly. With IVUS, people don't always know how to do it. And so the way we do it, just to show you, this is sort of the vessel size, which is outlined in the dotted line. That's the lumen size. You don't want to size according to lumen if you can see the vessel. And basically what you do is you take media to media, and you can basically discount that by a half step down. So if this distance and this arrow here is 4, you'd probably use a 3.5 balloon and or stent for that type of case. And it's pretty straightforward. With OCT, you can be more accurate and you can go down to a 0.25 if you're looking at EEL to EEL. Now, this is a poll that I did a few years ago, and I think I've repeated it since then, but the principle remains the same. And that is, we asked if your father was having a PCI of the LAD, would you or would you not want him to undergo PCI with mandatory IVUS or OCT? And the majority of people responded, yes, we'd want him to do it. So if you would want it for your father, then why aren't you doing it for your patients? And that's a really, really, I think, fundamental point that, yes, there are cost constraints and we have to work through them. But if you feel that's the best for your parent, then that's something you want to bring to your patients. And that's why, personally, I think, especially for complex disease, imaging ought to be mandatory. The final part about imaging is that low contrast PCI with imaging, I do think is game changing. I don't use the word game changing a lot, but I will certainly say this allows you to do cases that you would otherwise not be able to do. I actually had a patient who had a contrast allergy in the middle of the case yesterday, despite being pre-medicated for it. And we did the rest of the entire case with just imaging only. And we were able to do the case rather than have to stop and take her off the table for another procedure, even though and we wouldn't really know what to do because she was already medicated for the contrast. So the important part about contrast is that despite the fact that in the NCDR, this is a large registry here in the United States, we see that contrast volume is clearly associated with the rate of acute kidney injury. Irrespective of the risk of the patient, interventionalists basically give the same amount of dye, which is remarkable. It basically means that I know how to do the case my way. I'm going to do the case my way, and it really doesn't matter what the patient risk is. That's crazy. We shouldn't be operating that way. We should lower the amount of dye we give if the risk of the patient goes up. And the way we track that is by the GFR. And so what we try to do is give less dye than the GFR for our patients undergoing PCI. And the way you can do this is you do a separate low contrast angiogram and you separate out the PCI. You interrogate lesions using physiology to determine what you need to treat. And then with imaging, and wire guidance and actually matching this up to landmarks like the calcium and otherwise, you can place your stent successfully. And so this is just an example of that. And basically what we do is you put the stent in, you do it imaging guided, you expand the stent adequately. If you need to, you can check the post physiology, and you don't really need to give contrast. And this was published by Ziad Ali in European Heart Journal from our series at Columbia. Now, moving beyond imaging, let's talk about a few last things. One is hemodynamics and this issue of hemodynamic support. So when do you use hemodynamic support for chip cases? There's some people who say it's not a chip case unless I'm using hemodynamic support. That's not true. It's always going to be a complex or a patient who's higher risk for other reasons or something else type of case. You just have to think about the hemodynamics when you do it so the patient doesn't get sick. And so think about hemodynamic support when their hemodynamics are irreversibly bad. There's nothing you can do to fix them, or you're really expecting they're not going to tolerate what we're doing during the balloon inflations. And that last case was a perfect example of this, where because it's ISR, even though the disease looks bad, the patient's going to tolerate it pretty well for the most part, and the EF was normal, so you don't think you need hemodynamic support. I like showing this slide because it fixes the anatomy. What all three of these patients, each of these rows, each of these columns the patient have is a mid-LAD 90% and a prox RCA 80%. That's what they have. But look at the hemodynamic differences between this patient on the left with a normal blood pressure, normal filling pressures, and a normal cardiac index, and this one who has a marginal blood pressure, PA pressures are high, the wedge is 33, and the index is 1.4%. These patients with the exact same anatomy have completely different risks of decompensating during the PCI. So what I would do is the one on the left, I'd proceed, no problem. The one in the middle, I would proceed. And the one on the right, if you have to do it, put hemodynamic support in, but maybe just stop and take the patient off the table, diurese the patient, maybe give them some inotrope, tune them up, and then bring them back, and you might not need to use hemodynamic support. Now, if someone would say, well, why don't you want to use hemodynamic support? Well, the reason is because at present, it's another large bore access or a bigger access, and we'd like to do the case with the patient as safe as possible. So if there's no rush to doing it, there's no reason to jump into it at that time. So who do we consider support for? We basically consider it for patients with severe LV dysfunction or irreversible adverse hemodynamics who are undergoing multivessel PCI, and it's to support you during the stress of the ischemic burden during the PCI when we blow up balloons, and also contrast, because contrast does not contain hemoglobin and it makes people sicker. LV dysfunction with uncontrolled interruption of flow in a major branch, so difficult wiring, stent delivery, high risk of no reflow, or retrograde CTO through a major vessel. In other words, you're going to keep that patient ischemic for a longer period of time, and the patient's not going to tolerate that because the hemodynamics are bad. And if the EF is okay, we may do it in a patient with a last remaining vessel, but even that I put plus minus here. And as I said, the risk of hemodynamic support is real. There's bleeding complications associated with it. It's not something you would want to have done just gratuitously, and that's why it's important to think about when you're going to do it. This is for us, in our lab, when we tend to use it. I think oftentimes the cases with hemodynamic support get overrepresented on social media and other places because people are not going to talk about the type, A or B lesion they treated. They're only going to talk about their toughest cases. But that doesn't mean it's used in every case you do in the lab. And that's really important because the overall percentages here are quite low for overall use of hemodynamic support. And you modify what you're going to do based on pre-PCI hemodynamics. The bottom line is most of these scenarios involve low EF with some other threat of making the patient worse during the PCI, unless it's truly like a very, very high risk procedure based on the anatomy in a last remaining vessel. It's also important not just to show up in the cath lab and just do the case. Examine the patient first, look at the echo yourself, do the right heart cath, integrate all of these things together, look at the echo, make sure there's, for instance, no clot in the LV if you're going to use an percutaneous LVAD, and then manage the vascular risk as well to fully protect the patient from adverse outcomes. Volume and experience are critical, and these are the last two that I'll show you. Basically, if you look, for instance, at left main disease, if you're at the Fuwai Hospital in Beijing, which is the highest volume PCI center in the world, and you have your left main treated by a low volume operator versus a high volume operator, you have a higher mortality if you're treated with a low volume operator for basically the same low lesion subset. Now, of course, these things need to be adjusted, et cetera, but it's still an important point that in complex disease, experience matters. The same thing, by the way, is shown with CTOs and otherwise. And this is really important here in the United States, and India is not that dissimilar. in this regard, where you have a lot of operators who don't perform a lot of cases. These cases should be performed by people who are very comfortable doing them. And if you don't have somebody comfortable doing the case, then you should work with somebody who is together so that you can figure out the best way to take care of the patient and do it safely. The reason I say that is because if you look in the United States at left main PCI, this was a report that came out 2 years ago in JAMA Cardiology, only 17% of operators and just over half of facilities did more than one left main PCI a year. That is remarkable. It shows you how little experience there is doing it. And you need to do it well if you're going to do it. And so use imaging. In this case, imaging was used in the minority of cases. You had support using in a large proportion of cases, which may be because of the unfamiliarity of how to do these cases. And it's just not a good way to do it. So you need to have high volume operators. And the same thing is true with CTOs. This is data from the New York State Registry showing that CTO operator experience was associated with outcomes in CTO PCI. The following thing I'll say is you want to be a physician, not a technician. And that's really, really critical when you're talking about how to do these types of cases, because sometimes you need to not do the case. This is an example of an 88-year-old woman had a non-STEMI with a pneumonia episode 3.5 months ago. She was at home. She was doing fine. She came in for referred PCI. The disease is horrible, as you can see. And when I spoke to the patient and her daughter, she said that she was fine and she was satisfied with her current quality of life, limited by her needs, and knew that she was going to have a high-risk intervention and preferred to avoid it. So we left it alone. In addition, this is a case that was referred to us for 2-vessel CTO PCI, the LAD and the right coronary in a young individual. The circumflex is open. The collaterals are quite challenging if you can appreciate them. And here you see there's this conus collateral to the LAD, and the patient was referred for PCI but had symptoms and was otherwise a reasonable candidate. So the first question I asked is, why was the patient turned down for surgery? And the reason the patient was turned down for surgery is they felt that the lima there was no adequate LAD target. That to me seemed a little strange. And so what we did is we did a CTA showing there's an LAD there that's a reasonable target, and the patient went for bypass surgery. We could have done PCI and done 2 procedures, CTOs that are higher risk and more complicated, but for a long-term durable option for this patient, lima-rima, surgery is going to be a good option. And so that's important to do. That doesn't mean we only do surgery and we only do medical therapy. We need to use our skills as needed in the appropriate way. And so this is a patient who presented initially with aortic stenosis that was moderate to severe, an EF that was down, non-STEMI, and a tight left main and an occluded right coronary artery. The patient was actually transferred to our institution for surgery, but while on the floor, went into VF. Now, interestingly, the patient was on the surgical floor, and so the surgeons immediately cannulated the patient and called us to the cath lab because they could not defibrillate the patient because the left main was down and the right was occluded. But the patient was actually moving to pain because they were fully on support on ECMO, despite the fact that the patient was fibrillating. It's kind of a crazy situation. So we actually brought the patient to the cath lab, despite not really wanting to do it, but the patient was moving. We thought that we could potentially save the patient's life. So the nurses and everybody in the lab kept saying, we should defibrillate, but you're not going to be able to defibrillate if the patient has no flow. And so what we did while the heart was fibrillating on ECMO is we wire the circ, we wire the LAD, and then we ballooned to restore flow. We then defibrillated and the patient came back. We then basically completed culotte stenting of the left main. Here's what the final angiography looks like after kissing balloon inflation, where we've restored all flow and circulation to the left system. We actually put in an Impella to unload the LV because the heart was clearly going to be stunned. And the patient actually survived and was discharged with a full neurologic recovery. However, the patient had a vascular complication and had an amputation of the leg at the site of hemodynamic support. So this was a challenge that we had to deal with, but we did save the patient's life in the end. So just to conclude, I would just say the fundamentals of the CHIP mindset are that the indications for the case, the clinical indications, don't change just because a lesion is harder to treat. We need to train ourselves to learn how to take care of these patients, but we also need to know how to do it and when not to do it as well. And I tried to convey that in a piece I wrote as a response to a CHIP training document by Robert Riley and Jack in 2020. And I'll just read you what I wrote at this end. I said, despite its reputation as a technical subspecialty, interventional cardiology has always been about more than just the wires, catheters, balloons, stents, and adjunctive devices. It's the cognitive aspects of the field that are in many ways the most enticing. Knowing why, when, and when not to do something, and additionally, how and when to stop, are in many ways far more important than the actual technical aspects of the procedure itself. So with that, I'll conclude. Thanks so much for asking me to speak, and I'm happy to take any questions at this time. Thanks.
Thank you, Ajay. A great talk. Thanks for stressing the fact that interventional cardiologists should not work like technicians and see more like be responsible for patient, evaluate patient clinically, do echo yourself. And sometimes when you're planning these cheap procedures, it's very important point what you mentioned is a pre-treatment and probably diuresing them well and appropriately preparing them for elective cases at least is very required. And that's where I think our clinical skills also matter. And you've shown a tremendous case where we could also save. Sometimes I feel God is great. Some patients who are, in spite of all their sickness and arrest, they'll become all right. Some of them come walking and land in trouble. That's how these cases make us humble. And thanks for your excellent message for youngsters. And many of appreciations are coming in chat. Ajay, great message, and many of them are congratulating. The congratulations are fine, but any other questions or comments which anybody has had to ask Ajay, please feel free. Damodar, you deal with a lot of chip cases there. Want to ask anything to Ajay?
It's a great message, and the one sentence I really like from Dr. Ajay's message is the last line, that be a physician, not a technician. That is what we need to. And as far as the chip cases, as he nicely pointed out, that we have to think beyond the complexity of the lesion. We always look at the complexity, anatomical. Whenever we deal with PCI, we will talk only about the anatomical complexity. He nicely pointed out the filling pressures, LV function. But one question I want to ask from Ajay is that some of the patients, which sort of chip patients do you really put a prophylactic ECMO, anticipating this patient may, arrest on the table, and our impella may not give that much support in a no rhythm patient, in a very adverse hemodynamic patient, or will you go with only impella in such patients? Can you please enlighten on this?
Yeah, for elective PCI, I can't think of a patient where we needed to use the level of support that ECMO provided over the Impella CP for elective case. There are cases. There's one case I had not too long ago where the patient was really, really big, and we had to do a very complex PCI of the left main with atherectomy, and so that patient we put in an Impella 5.5 because of his size. But I'll tell you, for high-risk PCI, you don't need that same degree of support that you do for shock. And Sushil remembers, because he enrolled a lot of patients in the initial Protect 2 trial, and that was with the 2.5 device. And he has an amazing case that he was involved in where he dissected the left main, shut the circ down, and the 2.5 provided plenty of support in that case. So my feeling is that if you're going to use support, and as I emphasize, it's still the vast minority of cases. It's not a lot of cases, but if you're going to use support for elective PCI, typically that will be enough.
At least in cases who got a history of cardiac arrest in the recent past, would you consider higher support more than either a 5 Impella 5 or something like that in a case with a recurrent arrest with a history of recent VF or VT?
Yeah, if the patient is arresting, or actively arresting, that may be a patient where you just do it on ECMO, period, and then you can save money by just doing it on ECMO. But the shock scenario is different than the elective high-risk PCI scenario. Sushil, you were saying something.
Thank you.
No, I guess I was more asking a question for in India, the cost and availability of Impella versus ECMO. How is that factor into some of the decision making? And if you're going on ECMO, the importance of vascular complications, as Ajay noted in this one case, is an important consideration. And what level of support do you do on ECMO, and how do you manage the cost and availability factors?
In India, ECMO is available freely because the company also moves out on consoles, and our CT surgeons are quite comfortable, if not the cardiologists. In our place, we also put these devices. Especially in the COVID times, also a few cases were done, and the companies were supporting in various other hospitals. Whereas Impella is not given free. Actually, it's not given for shock situations in all the labs, all the hospitals. It is given only for some selected hospitals, but they are encouraging more for protected PCI type of indications rather than shock now. So that's a problem with Impella availability in various centers in India.
Yeah, I would also have to say that, you know, if you have AMI shock, which can recover, the CP device may provide enough support for that. But if you have truly, really deep shock and recurrent arrest and that sort of thing, we often end up having to escalate those patients to Impella plus ECMO, or, you know, the 5.5 or something more than what the CP will provide. So I actually think that that's pretty appropriate, because my sense is, especially if you have ECMO available, if the patient's in deep shock, you're going to find that the CP was not enough to take care of those patients.
Okay, I think if you have a few minutes, the Bangalore, they want to show the final image pictures before you leave.
Sir, I have a question.
Can you connect?
Sir, this is Ravindran. Sir, and my question is to Dr. Ajay. Sir, you are now this zero contrast PCI. I understand that it's low contrast, because maybe we need to have a roadmap in the first and the last pictures. And with the saline contrast available for the OCT, is it, and we also have a co-registration there, and we can mark the landmarks and except for the ostium. Is it a reality for the OCT to have a low contrast PCI with OCT?
Yeah, I think so. I would definitely caution you, though, that the size measurement is not the same. There are some people, I think there was a recent publication from India that suggested that the size is identical. It's actually not identical and may vary with the vessel size. So you have to adjust for that. The good news is that you're not going to oversize. The saline, you're going to get a slightly smaller number, but you have to think so you don't undersize in those cases. The other issue with saline is that it works well in the right coronary, it works well in vein grafts, but if you have an open left system, you're going to get not as good visualization in the left side. But you definitely can do it, and I agree with you fully. I would not call it zero. We do a diagnostic first, we then stop, we bring the patient back, and I personally take a picture at the end, because I don't think there's any harm in giving 5 or 6 cc's just to make sure you don't have a distal wire perf or some major issue.
So one more question.
Thank you, Ajay. We just listen to Secunderabad once because they're waiting. Girish, over to you. We are able to hear you and see you now. Show the final result.
Okay. Can we just go back to bifurcation stenting? Back. Okay. Play. Go forward. Okay. Please come back. See, you can see this angiogram. I think there was some hematoma because we dilated it to 3.5. And then I ended up covering with another stent. Am I audible? Next. Am I audible?
That was I was mentioning before. Check the distal extents of the stents before we decide and close. That's what I was. That came out true. Please go ahead.
Next. Am I audible, Dr. Srinivas?
Yes, we can hear you and see the film moving.
Yeah, wonderful. So we put another one that we undersized 315 and dilated it 3 distally and 3.5 in the overlapping segment. And go next. And then we did the bifurcation. Go next. Simultaneous kissing and port was done. There's the port that finally we did with 4.5. And then this is the OCT after that. Can somebody play the OCT? Before this, a lady OCT? Yeah. Can we show the OCT? Yeah. Yeah, you can see here no dissection distally, very well upper stent. The lumen is pretty good. There's good plaque thickness cut. And we're getting into now the triple layer of the stents. The nicely dilated vessel looks pretty uniform. Come back.
It looks way, way better. I mean, I think the whole sizing of everything is much, much better too.
Right. And now come back into the venous origin. Come back. So now ostium of the ramus, come back. Yes, go back, yes. So very well opened. The ramus, it's ostium, the ramus struts across. No crown, no struts. Next. Now when you go to the circ, come back. Proximal, yes. That's where the circ is. I haven't had time to open it. I don't have a heart to open it. Next. Come back. Yeah. Then show the final, the ramus to LAD. Ramus to left main. This is ramus to left main OCT. I didn't take it too distal because that would perforate the wire. And we just wanted to see the ostium of the LAD. The stem is pretty well open. Yeah, sure, this is the LAD. The ramus opening into LAD, no struts across. And now this is the left main. Go back, circ, go back, go back. This is the circumflex. There are some struts.
Hello.
Proximal. Keep coming. Yeah, beautiful. Whole left main is very well should come to the left main. Very well expanded. What is the area? Can you just tell them? 12.29 is the area that we've got. Mean diameter is about 4.4. And we can 14.2 at the proximal end. Come out. I think there's some little calcium, but mild eccentricity, but happy with what we have found. Any comments? That's into the aorta.
Okay. That's a good result. I think you also showed that LCX ostium is reasonably preserved and with no stunts across. And it's also important not to get into too deep in branches to avoid perforation. All that is well shown. I think the difficult case tackled in whatever ways possible. Congratulations, Girish. And
that's a great case.
Thank you.
Thank you.
Sushil, any final comments from your side?
No, I think the only point it's a great case, and just to the point that was made before about low contrast. I think one of the things about low contrast is learning how to do proper angiography. Again, low contrast doesn't just mean injecting a small amount of contrast. It's getting the right view, making sure the guide is engaged before you give contrast, understanding what you need to get from the angiogram. It's not just giving 5 cc's. If you give 5 cc's and don't see, then it's worse, right? Because you should get the information. And so I would sort of say in certain scenarios, maybe a guide extender into the left main to make sure you're well engaged and you're not refluxing too much contrast out. Using a medallion syringe, which allows you to inject 3 cc's, but setting up your shot appropriately to start is just as important as giving a low volume of contrast. And I think that's one of the things that Ajay was sort of mentioning and Ravindran was mentioning earlier. So, I think I just want to emphasize that point for the more junior physicians.
Thank you, Sushil, and thanks, Girish. Congratulations for showing an excellent case. It was chip session and ISR and CTO all were together, and we were fortunate to have Ajay and Sushil commenting on your talk. And Sushil, shall we go for your talk before we go for the other set of live cases, or are you ready?
Yeah, unfortunately, I apologize. I have to go because I'm on call today. I can.
Okay.
I was going to give a quick talk about bicuspid valves, just
please.
about TAVR and bicuspid, or I can come back if you want to go to the live case. Come back in a couple hours and finish up with that. That might be better. I don't want to interrupt the flow, so I can come back after you do the live case and the other lectures at the end.
Okay. Whatever you feel, because
I don't want to interrupt the flow because it's
45. You have 10 minutes.
Okay. Thank you. I'll see you a little bit later. Okay.
Thank you. Thanks, Ajay. And Ajay had another scheduled lecture for ACC as a lead person to give the talks there, but still you accommodated. Thank you, Ajay. And
thanks for accommodating me. It's just always great. I just wish we can see you guys because it's been too long. And stay safe. I hear the numbers are going up again now.
Yeah. I think, what is the status in New York?
It came down, but sort of like this now. But a lot of people have the vaccine, So I'm hoping it will keep coming down.
Okay, take care. Thanks, Ajay. We'll proceed further.
Take care. Bye.
Sir, can I ask one last question to Ajay?
Yeah.
Sir?
Yeah,
I just want to know how we will follow up this patient, sir. The case which we saw in live case, we know that he had already a multiple instant restenosis, and now so much of metal has been put in. So would there be any choice to use PCSK9 inhibitors for him, or how would you like to follow up this patient so that we don't have a repetition of this?
Yeah, I agree. I think that this patient needs to have everything as low as possible. And even if the LDL is low, I would still check like a little LP little a to be sure that's low. And if that's not, then I would give PCSK9. He needs close follow-up. He needs diets to be changed. And it's good for him to say that I don't want my chest cut open, but the only way to prevent that is for him to change what he does. So if he's smoking, I have a good relationship with my patients. They like me. And I'm honest with them. So if they're smoking, I will almost yell at them during the visit. I say it with a smile on my face, but I come on, what are you doing? That kind of thing. But I would not programmatically bring back for angiography, because even if you're going to find something, you end up treating it and you don't know if that's going to help. And I would probably do stress testing on this patient at a regular interval. So, but great question.
And how will we ensure compliance for this patient? So do we have any programs in your university to maintain the compliance of medicine?
We don't, but one thing that I sometimes do with, with some patients is every once in a while, I'll have the office or me or somebody call them and say, are you taking your medicines? How are you doing? And, India has the capacity to be able to do this, via WhatsApp and text messaging. And there've been some, not in cardiovascular space, to my knowledge, but in other areas like maternal fetal medicine, really, really effective strategies via text messaging that you can employ. And that's really important, because I can tell you that there are also times, a lot of times patients see the physician and they don't want to disappoint the physician. So they say, oh yes, I'm taking my medicines. But sometimes I call the pharmacy and ask them, when was the last time the patient filled the prescription? And they said, oh, 6 months ago. So then I call the patient up and I'm like, well, first of all, you shouldn't lie, because we have to be honest with each other. And second, please take the medicine. And sometimes that works.
Thank you. Thank you so much.
Anybody else has any final questions for Ajay? Okay, if not, then thanks, Ajay.
Thanks you, everybody. Take care. Okay.
And a lot of interest in the chip modality and imaging sessions in the country across. And your lecture helps a lot for youngsters.
I was also going to say that also with all this imaging that's being done in OCT in India, it's really great because you're leading. And a lot of people, I think, on this side are starting to see that there's more stuff being done in India, and then they can be inspired by that. So it doesn't have to be that everybody follows what the US does. And on a completely different note, I don't know if you know this, but there's a very, very big sporting event in the United States right now, which is the college basketball tournament, which is a big, big event. And yesterday in the main time TV slot, there was an iPhone commercial that the entire commercial is tabla Hindustani music bol as the background music. So India is definitely coming much more this side, and it's unbelievable. So keep up the good work.
Thank you. You all also make India proud, you, Sushil, and thank you very much for your time.
All right,
great.
Take care. Bye-bye.
Bye. Thank you. And tech team, can we go to the live case coming up from Kolkata? Welcome, Dr. B.C. Srinivas, sir.
Yeah, good evening. Good evening, all of you.
Yeah, Dr. Nikhil.
कागज पे नहीं है तो
Dr. Nikhil.
लिखे नहीं है वाला फटफट के उल्टा पल्टा वाला है.
Yeah, after we are able to see and hear you, just I am introducing the panel. I'm just welcoming the other panelists. Then we can go on to your case.
बोलते हैं. Digital landing जो ने.
Yeah, we are able to hear you, Dr. Srinivas.
Just nice give me a minute. Just I will introduce other panelists and chairpersons to come on. Then we'll proceed with the case. I think B.C. Srinivas is already here. Dr. Nikhil, was he able to join? Then Dr. Vikas Majumdar, he's coupled with you. Yeah, I think, thanks, sir. Dr. Ajay Bahadur, Dr. Roshan Rao, and Dr. Mandal.
I'm here.
Yeah, well, thank you. Dr. Devashish Ghosh, Dr. Vivek Bose, Ravindran is already here. And many of anyway, it's all our family meeting like it is. And we have two interesting cases, one from Kolkata, image guided physiology, multivessel PCI, and the other will be from Mumbai. And first we will have 15 minutes in Kolkata, then go to Mumbai and then come back finally to Kolkata again for the case. Over to you, Dr. Srinivas sir, to take over and moderate this session.
Yeah, good evening, all of you. Aftab, you can present the case and then you can let us know what you're doing.
Sure. So it's an honor for us to be together with you all. And just like to introduce the panel that is there with me. I have Dr. Bikash Majumdar here with me, who's washed up. Dr. PC Mandal is here. We have our colleagues here, Dr. Uday, Dr. Nabarun is here. My cath lab team with Mr. Bala and the other technicians, Mr. Bala, the chief technician, and I have Polan, who's the scrub nurse who's washed up with us. So I'll just show this case. This is a lady who's a 65 years old lady. Is the slide visible to you?
Yes, you're able to see
the slide. The next one. Next slide, please. So this is a 65 years old hypertensive lady who had effort angina for the last 4 months. And she had a syncopal episode and she was admitted in another hospital. She was noted to have a complete heart block with unstable ventricular rhythm. And she had to be put on a transvenous pacing. An invasive angiogram was done there. And she was then transferred to our institute for further management. Next slide. Her echo shows a normal wall motion, normal LV with no ejection, with a no wall motion abnormality. Her creatinine is normal. HbA1c is well within control. And her precise DAPT score is 18, which gives us a good idea that since she's going to be on a DAPT based on her coronary anatomy, this is something that we routinely use for assessing the bleeding risk vis-a-vis the thrombotic risk for our patients. In view of the fact that she came for a complete heart block and a syncope, we said we'd probably do the pacemaker first and then do a PC at the stage procedure. We've now started doing physiological pacing, and this lady underwent a physiological, that's a left bundle branch pacing with a Biotronic Select a 3D lead with a Soleus lead. Next slide. And this is how the ECG looked with the temporary pacemaker on. You can see that she's in complete heart block. Intermittently, there are a few conducted beats which are narrow, whereas the apical pacing from the temporary lead gives you a broad QRS with a superior axis. 2-3 AVF are negative, and the anterior lead show an LBB pattern. Next slide. And this is what we see as a physiological pacing. You can appreciate the wonderful narrow QRS, which simulate the normal conduction system. And this is what a left bundle branch pacing really does for our patients. It gives you physiological pacing, gives you very narrow QRS, and hopefully in the long run will preserve our LV also. Though we don't have data for this as yet. This was the lead position. Next slide. And you can see the septal position of the lead. Next slide. And this is how the left bundle lead would probably look at. Next slide. So coming back to the coronary system that we are basically here for. And this is the right shoot that we've seen. I think, can we go live onto the camera, Bala?
We're able to see the angio pictures.
Yeah, so this is the right coronary artery. It's a huge mega dominant right coronary artery with some proximal plaques. And next slide. Next image. So these were the images that were done outside, and you can see that there's no pacing lead, and this were the images done there. Next slide. And this is the coronary anatomy. So if you look at the left system, there are two basic lesions that we're concerned about. There is a OM which is shows a critical proximal disease, osteoproximal disease, and the circumflex, which though is a non-dominant vessel, has some disease at the ostium of the at the origin. And the left main looks normal. The LED in its proximal part has some plaques. The next view. Next slide. Okay, now this is what we did this morning, just now. So you can see that there's a circumflex disease at the origin, and there's an obtuse margin which has a critical disease angiographically. The left main seems to have a plaque in the distal part. The disease extends into the ostium of the LED. Next slide. Next view. Next image.
We can discuss now.
And this is the cranial view, and you can see that there's a critical disease in the mid part, and with the disease in the proximal part, and the distal LEDs is pretty good sized, and there's a diagonal which looks a good caliber vessel and has an osteal disease. The next view. No, just show the next view. The back. Yeah. So this is the spider view that you saw already. So this is what we now have. We have this lady who has a dominant right, which is normal, and a lesion in the LED. critical in the mid part, some plaques in the proximal LED, and an OM lesion. We'd like the opinion of the panel to understand how would you want us to proceed with this case.
After a great case, actually, because see, you have a issue of AV conduction disturbance along with coronary artery disease. And the way you manage the AV conduction, it is an excellent way. I think LBB, left bundle branch pacing, is the way to go, because you clearly demonstrated physiologically that that it's a narrow QRS you have been able to get with the left bundle pacing in your case. Definitely it will go. I think logically it will definitely go a long way to reduce the LV dysfunction on follow-up. I do not have any doubts with respect to that in my mind. And then the lesion which you are showing now, the definitely the disease, actually there is severe disease in the mid and the proximal LAD. Distal LMCA is definitely disease, no doubt about it. And then the OM definitely has a critical lesion. Now, if we are planning to manage this, anyway, this I personally feel we should image this vessel well, so that we understand the extent of disease in the LAD and the extent of disease in the left main. How far are we going to come into the left main, the stents, if at all? And obviously it has to be a two-stent strategy, no doubt about it. One from the OM back towards the either in whatever way you do till the proximal LCX are into left main, and then one more from mid LAD back into the left main. So I would image these vessels before we actually plan the procedure.
Any other opinions that we would like to have? I mean, could you get any other opinions? So you want imaging first, or would you want us to do?
I think if you are planning to do imaging, it's fine. Otherwise, the critical lesion looks like at the point in the mid LAD and the diagonal osteal origin.
Right.
And OM, though there is a disease, but still LAD diagonal looks more critical to me. In Kolkata, it appears that even ischemic patients present more with heart blocks or what? Because generally pacemakers are quite common in Kolkata.
Very, very common. Yeah. Very surprising, actually, Dr. Srinivas Kumar.
Yeah.
It is so,
even if this patient
so
has presented with block and effectively managed, and what I would feel is,
so I think the challenge here was
just one thing. You are planning to do the double stent strategy involving the distal LM. That means from LM to LAD and LM to circumflex to OM. I think better to assess physiologically fast. If the OM lesion is not physiologically significant, we can assess the LAD. And if LAD proximal is also not significant, then you can make it simple. That with one stent, we can stent that critical area only.
So, you know that with Dr. Mondal, we were actually did the physiology first in this particular patient. We did an RFR of the LAD, and also we did.
So I think we'll just go and show you what exactly we did.
Yeah.
And next slide.
Next slide, yeah.
Yeah. So what we had is that since I've done this as a radial procedure, it was a little difficult for me to disengage my guide to equalize the pressure wire. And this is something that often I do, that you put in a wire to stabilize your guide, and then you disengage the guide and use the wire to equalize your pressure wire, because sometimes it's difficult for you to get in and out, especially when you have a arch which is or you have a radial curve, which makes it sometimes difficult, and you don't want to traumatize the left main. You have to make sure that you still have a good equalization. You make sure that you get your introducer out, give adequate nitroglycerine, and you keep your pressures up before you do any pressure wire measurements. So this was a tandem lesion, and therefore we said that it's better for us to use an RFR rather than using an FFR, because a pullback will then help us to understand where exactly the gradient is.
So we did an RFR, and you can see that we definitely had a gradient. Distally, the RFR, can you show that?
RFR of LAD, no?
Yeah, RFR of the LAD. Distally, you can see the RFR is pretty significant. It is 0.58. And then we gradually did the pullback, and you can see there is an area proximal to the diagonal origin. There was a significant step up.
Diagonal 2.
There is a significant step up. Just show me that, the step up. And you see it's just gradually went up to 0.95. So it indicates that the area which is distal to the diagonal is actually physiologically significant, and the area which is proximal to the diagonal is not significant. The cutoff value of RFR being 0.89. So you see the distal it is 0.58 and the proximal to the diagonal origin it is 0.95. So we even pulled it back towards the left main. And Bala, can you just show that?
So you have it in the inside there. You can see
focus on this screen here.
Can you see that? There is a significant jump from the proximal to the diagonal ostium, the origin of the diagonal. And then even we came proximal to the proximal LAD. And can you show, Bala, the proximal part? Can you please go back?
We need the thing on the main screen.
Yeah. So up to the left main, we just did the pullback, and the entire proximal artery actually did not show any significant RFR, means it was always more than 0.89. So this helped us in a way. Can you just show that, the proximal part of the LAD?
Okay, so next we also did an RFR of the, so this was the LAD. We also did an RFR of the OM branch. So this is in the proximal LAD and the left main, where we see that there's no real step up there to suggest a significant stenosis there. Next view. The RFR of the circumflex was also done. Bala, next.
Yes.
And this was the RFR of the circumflex, where we started off with an RFR value of 0.95. And then really no gradients to suggest a significant amount of hemodynamic lesion, which could cause a problem. So now what we are stuck with is an anatomy vis-a-vis a physiology. And I think with the data that we have right now, we still would go with physiology because that is what science tells us. But again, the lesion in the proximal LAD did not look too clean to us. And therefore, we said we'll do an imaging also. And we've done an imaging of the LAD.
Can you show that, IVAS? And
even the imaging wise, the angiography wise also, it didn't look that tight, no? It looked like mild disease.
So the one thing is that we thought that at least the OM, proximal OM lesion could have been significant angiographically, but physiologically, it did not show any significance.
That suggests the area of supply is also important.
Yeah, the other issue was that we needed to land the proximal stent of the LAD in an area which has a lesion less than 50%. We know from our IVAS data that if you land it on an area with a lesion of more than 50% plaque, you're likely to end up having more events relating to peristent stenosis. So it was very important for us to select an area where we land a proximal stent in an area which is so-called healthy with a plaque burden of less than 50%. And therefore, we thought imaging would also complement our placement of our stent wherever we plan to put it in the mid part of the LAD.
So we did the IVAS of the LAD only, and the idea of doing that IVAS in the LAD is to find out that distal landing zone as well as the most stenotic part as well as the proximal landing zone, And can you see the IVAS?
No.
No.
Not yet. Okay.
So what's the thought on Dr. Srinivas? Yeah. So this is the IVAS.
Now we are able to see the IVAS.
Yeah. So this from the pullback from the distal LAD.
Yeah, you can just see that
it's stuck.
Distal LAD.
It's moving. Go ahead.
Yeah.
Can you see it?
Yeah,
we can see it.
Yeah, distal LAD is around the 3 millimeter vessel. You can see that. And with coming to the most stenotic, there's delay in there,
There's a lag.
You can move, scroll, move the bar.
I think it's moving in our image, but it's not moving on the camera. It's moving on the console. So anyway,
you're able to see the movement.
Yeah. So just to tell you that you'll have to trust us with this, that the distal LAD was a 3O vessel, and the most critical area in the mid LAD had an MLA of around 1.8. There was some arc of calcium of around 180 degrees. And once we pulled it to the proximal part of the LAD, we found an area of landing zone with a plaque burden of less than 40%. There's a delay in your lag in your.
And the proximal landing zone is around S1, that means septal 1, in between septal 1 and diagonal 1.
Oh, that's fair enough. What is
Yeah,
the
we can
ostium of
see it,
LED look
actually.
like? Because there is a,
Just show the
you
bookmarks
thought that
again.
there is
Show the
a
bookmarks.
normal zone proximally where the stent can land, just proximal to the diagonal.
No, this is
But
the
just
left
to
main. No?
make sure, what is the LED ostium?
Yeah, so this is the left main. The left main has an MLA of more than 8. Yeah,
8.8.
yeah. So next, it just shows the hostel LED.
The proximal LED. We took
Proximal
bookmark.
LED.
Proximal LED. Bookmark is there in the proximal LED. Yeah, proximal LED was about 6.6 MLA. So that was pretty good actually.
And a plaque burden of around 50%.
Yeah. And if you look at the proximal end where we plan to
land the
stent, that area is next bookmark. Yeah. That area is about.
No, that's not the one.
This is the LED. Sorry. The next bookmark and landing zone. The landing zone is around 6.6. The LED was about 5.5, around 5.5, but the landing zone is about 6.6 MLA, and
diameter
6.6, and the diameter is 3.1.
Okay.
3.1. So that's the proximal part of the landing zone that we decided that we should be stenting. So, and the other thing is, of course, that is the critical stenosis of the diagonal ostium. So we decided to wear the diagonal. And
so any thoughts on
just
this?
for sake of listeners and viewers, it's a very important message in this case. Unless it is required, don't come on to the left main and do great heroic things.
Absolutely.
And as you see, always it is possible if you can avoid it and do a quick job. Now middle LED and diagonal doing is different from left main bifurcation. Unless it is absolutely essential, don't come on to the left main and proximal LED, and the area as well as FFR, both you have proven that it is good enough not to do anything there. And the proximal landing zone fortunately is there for us to place the stent there, and you can just start from there and go distally and do a stent.
Yeah.
Yeah,
So
great message, Dr. Srinivas. In fact, in this case, both physiology and imaging are actually complementary, and they're in fact giving the most important information that the focal treatment is much better than the entire vessel treatment in this particular case. No doubt, both of them are actually giving us the appropriate direction that we should just treat the mid LED lesion, and rather than coming into the proximal LED.
I think truthfully, probably if it was a decade back, we would have gone and stented at the LED. But I think with the science that we have now, I think deferring this lesion in the proximal LED is probably the way out. And I would agree with you that our intention would be to treat the mid LED, preserve that diagonal branch, and then redo the RFR, because our intention is to get a 0.95 in the distal LED post intervention. That is what our plan would be.
Yeah. Did you proceed further?
No, we're just waiting for you. So we will proceed ahead. And if you wish, you want to go back to Bombay and come back, we are happy to do that for you. Or if you want to be with us, we are always happy to be with you.
Absolutely. You go ahead, Aftab. I think we'll go to Bombay and then come back.
So the intention is that there's a calcium of around 180 degrees plaque. So we'll probably use a Wolverine balloon to do a cutting there and debulk that lesion in the mid part of the LED. Yeah.
And obviously, you will also wire the diagonal because the diagonal ostium looks diseased. And
so the plan is to use a gel balloon technique. So probably I'll gel that balloon, do a gel balloon technique to preserve that ostial diagonal. It's got a bad takeoff and critical lesion, so I don't want to lose that diagonal in the first place. Yeah.
So it's a provisional strategy. You are not going to do anything upfront for the diagonal.
No, I don't think so. No, we don't want to.
Yeah, absolutely, because it's a short lesion, less than 5 millimeters from the ostium.
Sure.
Absolutely.
Okay. Kiran, can we go to Mumbai now? Let us see what Rahul and others are doing there in Mumbai. And keep Kolkata on mute.
Okay. Are we heard?
You are heard.
Yeah. So hi everyone. I'll just introduce my team. I'm Dr. Rahul Gupta. Dr. M.G. Pillai sir is there with me, and Dr. Haridas Munde is our cardiac anesthetist. Arun is our technician. So the case which we are supposed to do today was done yesterday because he became unstable, and this case is also very interesting. We'll just show you the images. We have just started wiring the thing, but we'll just show you the images. Angiography done just some time back. So he has presented, he's a 70-year-old guy, non-hypertensive, non-diabetic, and he presented to us with anterior wall MI yesterday, and he was thrombolized with tenecta place. Now we did his angiogram just an hour back, and it is showing a tight distal left main lesion. As we can see, appreciate very well in this view. There is an aneurysmal dilatation in the proximal LED. And
can you show the angio pictures?
Yeah, can you focus on the angio?
Yeah, we are able to see it.
Yeah, okay. So go to the LA caudal view, please. So this is the one. There's a tight left main lesion, and there is a aneurysm which we can see in the proximal LED. And there's a mid LED tight lesion, which was the reason for his MI this time, because it was like the regional wall motion abnormalities in the mid LED territory. And there's a LED diagonal bifurcation. There is aneurysm, and if we look into the OMs, there are 3 branches going into the after the LCX, which is, and there is about 70% lesion which we can see into this area. Can we go into the LA cranial view, the cranial view? And this is the mid LED lesion, which is probably the culprit. And we have a large diagonal which is coming, but the mouth of the diagonal is looking quite okay. Can we go to the RCA? And this is the RCA lesion. There is a 70-80% lesion. And again, this is a bifurcation. So because it's an acute coronary syndrome situation, we have planned, we and Dr. MG Pillai discussed, and we discussed with the family about the options of CABG versus PCI. And they wanted to get a PCI done. So we are planning to do only the left system now. So we'll be just starting. So comments from the, Sir Pillai, sir, you want to say something?
Well, multiple bifurcation lesion, and we wanted to present something interesting. So we thought this would be an ideal case. We have taken an informed consent, explaining all the details, expenses. So Rahul has spoken to you. We have wired the LED diagonal and the circumflex.
So we'll go to the present. Any suggestions from the approach which we should have? So what I've done is I've wired the diagonal LED as well as the circumflex.
Thank you, Rahul and Pillai sir, for in doing such a case in tough, challenging times of COVID in Mumbai. We were worried because of COVID we would not have a case. But finally, you got a case. God is great. You got a case which is absolutely suitable for live transmission, it looks. But we need to be careful because of the ACS situation and there's a left main. This is also apart from the mid LED, diagonal and other bifurcations also. Go ahead.
So we are now dilating the mid LED lesion. Yeah, it's open. Negative.
Yep.
Yeah. Any suggestions, any ideas? We are going to do the OCT after this once we have dilated the left main and the LED, and then we are going to do the OCT. We'll see the OCT run.
With the same balloon, we are opening the left main.
Okay, this is open.
As Vishavik, Kolkata type of different case, what we saw here, left main looks important.
Yeah, it's
angiographically
critical.
also. And he has LED diagonal bifurcation. This is more a sicker patient ACS type of scenario. As you have seen, you need to wire all the vessels, branches, LCX and the diagonal LED are all wired. And the tightest lesions are being pre-dilated. And after doing imaging, they would decide further what needs to be done.
What do you think about the OM lesions? What does the panel think about the OM lesions? We are planning. We are planning.
What is the LV function? Did you mention about it?
LV is about 40%.
Okay.
Yeah, good evening, Dr. Pillai and Dr. Rahul. Srinivas here from Bangalore. Greetings from Bangalore.
Yeah. Hi.
Now, the thing is, when you have a situation of anterior wall MI, I would stay away from the OM lesion because it's flowing. Because any slow flow in that zone, you will push him into hemodynamic instability. I wouldn't touch the OM lesion at this point of time. Okay, yeah, left main is critical. I think, yeah, you treat the LED diagonal and then treat the left main and come out. I would stay away from OM at this point of time.
Yeah, that's what we are thinking. And if everything goes well, we are just planning to do, because it looks borderline, so planning to do an FFR once we have fixed up the LED diagonal and everything, left main. That's what we are planning. Any suggestions on your side?
Yeah, as we know, LCX ostium is always a difficult animal to actually do good job. So it is better to avoid unless it is absolutely essential. As sir mentioned, probably a crossover stent if L6 ostium is preserved would okay. And anyway, OM lesions are borderline, you need not address immediately. And there's another message for youngsters that in acute MI type of situations, do the culprit vessel, and all the trials also showed stage PCI is better, but you need not be on the same procedure time. It can actually plan it again pre-discharge and do the right one later. and keep OM on OM borderline lesions and follow.
Yeah, that's
Yeah,
what
the
we discussed with the
trials also have shown, Dr. Srinivas, either 48 hours or 2 to 3 weeks down the line. You can do once the LV has remodeled positively, then you can take them and then more.
The only challenge here, what they're thinking is because LCX will be jailed with the stent. If you have to go later, it will have some trouble. That's why some people do just minimal soft dilatation of ostium to not to have stents across. At the same time, not to injure the LCX, so that passage of further stents and things would be easier. Let us see how the case goes. And did you do imaging? Are you planning to do OCT?
Yeah, we are doing the OCT right now, just arranging because we took up this case on the table at 6:45 after a lot of discussion with the relatives. There was another.
So if you want some time, we can go to Kolkata and then come back to you.
Meanwhile, we'll just do an OCT and measurements and then we can come back.
Okay.
Yeah,
That's
I
fine.
think that's fine. I think we should allow them to work peacefully.
Yeah. OCT wants to show before we go.
Okay.
So you can go. I'm just we are just connecting.
I think we'll go to Calcutta and come back.
It'll take about 5 minutes, 2-3 minutes.
Yeah, other panelists, Dr. Ajay, Dr. Roshan, Ravindran is anyway
Ravi,
there. Anybody
yeah,
has any comment, feel free to talk. Any comments on the case? Sridhar is also joined, Ramakrishna, Ravi Bhattana. Anybody has anything to say? Subro Banerjee, I think from Kolkata. And many of us, this is another way to know and learn and make friendship with each other. So use this opportunity and so
absolutely.
that we know each
Absolutely.
other. Yeah. I think finally you got a good case, Rahul. Initially, we were thinking whether to get a case, we'll get a case or not. We had discussions in the afternoon also, but finally, God is great. You got a good case
We
for
did
that.
4 angios since morning, one post CABG, calcific, but grafts were working fine, but then we decided that this is a better, there was a new LCXOM bifurcation region.
I think when you're doing it, you can show, the camera can capture how you're threading the OCT catheter and other things for people, for youngsters to learn. I think this catheter Dragonfly system is now improved better. Previously, we were having a lot of challenges to thread the wire onto the OCT catheter. It always used to go and hit the imaging crystal. Now they've changed it, and if you hold it below and the wire directly comes out without much of challenges in wiring that catheter.
Correct.
The camera, can they focus on that? Make that connection bigger, the OCT is smaller. Now we are seeing the OCT bigger and what they are doing smaller. Yeah, now that's better.
You're already.
And when you're taking the catheter, the Y connector also has a two screws, 2 plugs on it. One you can keep it open, and one you can close, not to have too much bleeding. At the same time, the catheter moves in freely. So unless if you keep it totally open, then there will be bleeding. If you keep it closed, then it will be tough to go. So probably if you have Y connector which has 2 knobs, one of it can be open.
Okay.
And you have angio-co-registered, it looks like the lab has co-registration.
We have a co-registration, but they have taken the output for the camera. So we might not have an angio co-registration right now, because that's what they said. You can either have a registration or the output, something like that.
No problem.
Can you give me a fresh dye? 10 cc.
20 cc dye.
Now can we see the fluoro? Ajay.
Can you see the OCT thing?
Yeah. Yeah, we are able to see it. Go ahead, take a picture. It's very important to flush the catheter and see that there's a bloodless field, and then take a proper, engage the guide catheter well, and then inject so that you get a good picture. Otherwise, a lot of blood artifacts.
Enable pullback, please.
Need to have a good coordination with the tech and the person who is injecting, so that simultaneously it happens. The pictures would come better.
I think we have obtained a good picture. There is clear, a normal looking distal vessel. There is significant disease there.
I think all of you can see the OCT images.
Yeah, we are seeing it.
Yeah, okay.
If you have done a pre-dilatation, you can see the fraction.
There are small micro dissections which are produced by pre-dilatation balloon.
Yes.
Now you have come to the proximal portion.
Yeah, you can see the aneurysmal segment and the circumflex.
Okay, that is the
This is that aneurysmal segment, and this is that distal left main lesion. Distal left main lesion.
That is the important image, that distal left main lesion, which is critical well. And the proximal left main looks disease free again. That's good.
Yeah. We'll take the measurements and then we'll start planning. So idea is to put 2 stents, one from distal to the diagonal, the healthy area we will see, and then put it just distal to the aneurysm. And in the aneurysmal area, we will take a larger stent, which will take it to the ostium of the left main, near to the ostium of the left main. So that's the plan.
I think ostium of the left main can be avoided at mid shaft. It can start because ostium looks totally free from disease.
Yeah, so we'll just check that and we'll come near to the
quite voluminous.
Yeah, that's true. And then the precise, can you just measure the length and show what is precise length measurement on OCT? You can measure exactly what length you have to take it.
So I just go to the OCT side.
Yeah, that is also okay. The area, the diameters also measurement is showing from normally EL to EL, we take it in the OCT, whereas intima to intima, we do it in IVUS. So if you know that EL to EL, probably quarter undersize, that would be okay. Maybe 3.25 is showing 3 mm stent, little expansion.
3 mm stent should be okay distally, and yeah, just take the length from the till distal to the aneurysm. Take the proximal thing. So let's go to the aneurysmal side and see how it. Okay, so this is the aneurysm. Just go distally. Yeah. So idea is to place the stent just distal to the aneurysm. Just go distal to the aneurysm.
Yeah, the 35 or so, that looks like literally better segment, which is more closer to 3. At 35, I think you can end up the proximal stent, and the distal stent can come into that proximal stent.
No, little distally.
Yeah.
Oh,
little distal. Maybe at 12.
There's a plot there at 11 o'clock.
Come to this area. Come to this area. Come distally. I think there are some plaquish as we could see in the LED.
Yeah.
We'll go to a healthy. This is a plaque.
Yes.
Come distally.
Little
Maybe
more.
this is a healthy area.
Yes.
So I think we should plan from here to the which is around 30 millimeters. So we'll take a 30 millimeter stent and 3.0. If everybody agrees, just measure the diameter over here. Distal
approximately
from the.
This is the beauty of imaging. You see, the OCT precisely guides you the exact, the length, the exact
Coming, I think we can take a 2.75 stent about 30, and then we can dilate it, and then to up to
2.92 horizontal.
Yeah.
We can take a 3 at low nominal.
Yes.
That also
take
we can do.
Nominal pressure and stretch it up proximally, because lumen is huge.
Okay.
I think that's the better way. I think 3 would be a better way.
Okay. 330.
Yeah.
And I think the diagonal is pretty. The ostium of the diagonal is looks disease free, so I don't think so. We should have an issue.
Here the area is 17.88. It is really aneurysmal.
What is the size of the aneurysm, Jesse? Diameter.
5.66 in one dimension and 4.75. 5.6, yeah, 5.5.
We'll have to dilate to that level.
Yeah, whatever you do, sometimes there could be some sort of a slight malposition in those aneurysmal segments. I think the maximum strength we have is maybe 5 mm, and the left main is also luckily 5 mm.
Yes.
But we need to be careful where you're ending the distal 5 mm, because it could dissect this LED. But we are ending, fortunately, in the distal stent. That's how I think we can.
So we will open it at a lower atmosphere, pull it a little back, and then maybe optimize it.
Okay. So what are the stented? Distally, you said 330, and the proximally it looks like 5 mm into. You can measure again the length from the mid left main to.
Arun, can you measure from the aneurysm to the near to the ostium of the left main?
You can go slightly more distal.
No, the diameter length. Length measure karo na.
From the previous stent into the ostium of the left main.
From 30 to 55, maybe 25, 26.
There is an aneurysm. Then come down. Come down. Come down. Come
Okay,
down.
we'll take
come
a
down.
shoot for
How much it
we'll
is?
just see.
Yes, that should be okay. What is the length? 10.5. 12 or 15 we can take. We need to overlap.
Is this?
Yeah, that looks good.
Can you see the fluoro? I've placed the stand and I can take it little back. Little.
Actually, I have angiocholesterol. It helps exactly same points you can do it and same things you can check on the OCT.
Yeah.
I think we can go proceed with what you're doing it, and we'll see the cine pictures of.
Can you put us? Just check, sir. Yeah, this looks
that's
okay.
fine.
Can you see the cine?
No, we are seeing the OCT bigger. Make the cine bigger.
Cine ko bigger banao na.
Yeah.
We'll go.
Now we are able to.
So we have pulled it little back, just distal to the aneurysm. Where we have placed the. I'll just show you. This is where we have placed the
at the mouth.
At the mouth. Let's go, sir.
Exactly.
We'll go a little.
Yeah, we will go at 8, 9, 10.
Yeah, maybe little. Yeah, it's fine.
9.
We'll open it a little low, see how is it distally, and then.
What stent have you taken?
This is 3 into 30 onyx.
Okay.
Can you give me some nitropicide?
The proximal diameter, whichever is bigger, I think you can select that stent because
yeah.
Proximal.
Because we are going to open it in the thing only. Can you, sir, go once more?
I'll go. You want to withdraw a bit?
Yeah. You can go just one more 8 or 10 lower pressure, and then.
We are at 8.
Yeah, this should be enough, sir, because it's 2.75.
Can withdraw a bit further.
We'll withdraw a millimeter back and just give little
higher pressure.
We are at 14. Okay.
Take this. No?
So holding it.
Okay. What was the length which is coming for the left main to this thing? I think this this looks okay.
Can we have an RAO view?
There's already a step up distally.
Distally, we also can confirm
and
the diagonal ostium.
Diagonal ostium is looking okay.
Yeah, it's well maintained. I don't think there's
so
any
we will.
issue.
Yeah, it should not be an issue. We'll place the proximal stent. I think we can remove the diagonal wire.
That makes it simpler.
Yeah, that's important to remove. Otherwise, 2 layers of stents.
Layers of stent and with the overlap,
it
will be an issue. So left main is coming. How much? 5. Do we have a 5 millimeter stent?
I think Onyx has a 4.5.
No, they have a 5 also. No? They have a 5.
Do we have a 5?
Yeah.
What was the?
15. 15. You 15. There'll be a little freedom
Should
of
we
overlap.
dilate the left main lesion? It was soft. We have dilated only with 2.5.
It's okay. It's okay. So whole lesion is soft.
Yeah.
Despite he being 70, the lesions have opened up at low pressure and there is no visible calcium.
And the ACS type of presentation, lesions are likely to be softer than not.
Absolutely.
Even the OCT shows more of fibrotic plaques rather than calcified plaques.
Can I have some light?
Can you go which is the healthiest area in the left hand? Just show me. I think.
This coning like this,
Yeah.
so we can readjust it accordingly. There is no disease
can you
segment.
just- yeah.
It is not a disease segment, so we can appropriately just go to the distal, overlap it.
Even if 2-3 mm bigger, also it's fine because proximal area is all healthy. Though we should not miss out. That's all.
Absolutely. Twist and boost.
We'll open at lower pressure and then. Hey,
We can have a stent boost.
I think this is okay. The proximal part
Yes,
is
just
okay.
one.
Just PA cranial stent boost. Just take a stent boost. How much overlap is it?
I think it's just adequate.
Okay.
Yeah.
Oh.
fine.
थोड़ा सा जाओ ना cranial.
Distal overlap is fine. Proximally.
The overlap is looking fine. Yeah.
Proximally, whether you are there in the.
There's two struts. Two struts are there inside.
Yeah.
Take a little alloprenal and just see the proximal thing. I think this is also okay.
Perfect.
Correct.
It's fine.
Yeah.
We'll go a little less. Because,
10.
Yeah. We'll stop, sir.
Okay. 10.
Because that area is not that. Yeah.
What size it is? What size?
5 or stand.
515.
515. Yeah.
515.
He's holding well.
The same thing you can take little more inside and do high pressure dilatation in the overlap segment and as well as near aneurysm.
Overlap, I don't want to give high pressure with this balloon because that
Maybe low pressure, Rahul. Yeah.
Low pressure or take a bigger balloon with aneurysm.
Yeah.
Yeah. So that we will do. We will just massage a little bit at the overlap, but not very high pressure.
Yeah.
Yeah. Agree with you.
Yeah. Yeah,
Okay.
this is fine. Yeah, yeah, this is fine.
Yeah.
And we'll optimize further. We'll take a 3/0 for the, we can dilate it further. And we'll take a 5.5 balloon. What was the diameter? 5.5 balloon is there? Yeah.
Sure.
Can you just go into, just to see the circumference, can you go into the aleocaudal? We'll take a aleocaudal picture just to see how the circumflex ostium is looking. It's quite tight now. You'll have to go and do some POBA in that area.
No, we'll do a pot and then
First
we'll take
do a pot and then we'll take the
a short balloon. Hey, short balloon.
5.5 into 6.
Would you like to rewire the LCX before you do that, or will you do it after pot?
No, this balloon here.
After
not-
pot.
After pot, I will rewire the thing. We'll just keep it, you know, huh? 6 nahi hai? 8 should be okay, I think. Huh?
Let's see.
I think Rahul, great going. I think you again do pot and rewire LCX and do a small kiss with minimal projection and then
Yes.
do a final OCT. We'll
Right.
just go to Calcutta and come back to you in
Calcutta,
5
yeah.
minutes. 10
Yes.
minutes,
Okay,
15
okay,
minutes.
yeah.
They are ready with the final result. We'll come back to you in the end. Okay, that will help you to work in peace also.
Yeah.
Okay.
Yeah. Thank you. Sir,
Can you switch to Calcutta?
Yeah, go cranial.
Thanks, sir.
Yeah, Aftab, we are with you now.
Yeah, so we missed you and we were doing our work. So we'll just show you what we did. So just 1 second, I'll just park this wire here. Yeah. So we left you with the mid-LED lesion, which we decided we would stent. And this was a patient with had an RFR positive and morphology angiographic negative. So we wired the LED and the diagonal. So this was a routine workhouse wire in the LED and a fielder FC in the diagonal.
Keep showing the CNEEP. That's it. Okay.
So we pre-dilated with a Wolverine balloon because we saw some arc of calcium of almost 180 degrees. And well, we felt that this is better to debulk now with a cutting balloon rather than be sorry later on. So this was a 2.75 balloon, and we went almost up to 18 to 20 atmospheres. And there was an arc of calcium which we really could not crack, and you can see it on the medial aspect of the LED. The other wall tend to give up, and therefore we have to be careful with these cutting balloons, especially when you don't have a complete arc of calcium, because you could rupture the other end, which does not have a lot of calcium there. You can see the angiographic flaps that were created, and this is what, of course, is the intention of the balloon. And again, we can also realize that there's a tight pinching of the plaque shift with a pinching of the diagonal ostium. And this is something that we need to be taking care of also, because we didn't want to lose that diagonal. Next. So we did what we normally call as the, so this is the other non-compliant balloon also that we used. And well, this is the result. Next. Yeah, so this is the technique of jailed balloon technique, which has been described by Professor Saito. So that's a 1.5 by 10 balloon in the diagonal. So diagonal is an artery we are not like to do stent, but that's an artery that we don't want to lose. So a 1.5 10 balloon there, and this was a 3 into 38 stent. And both of these were inflated simultaneously at 8 atmospheres. While keeping the proximal landing zone just after the septal branch. And that was the area we had decided on IVUS and on the RFR to be the healthy zone. Again, the balloon inflation, you can see that there is a little bit of wasting in the mid part of the LED. The diagonal balloon opens up well. Again, this is the modified jail balloon technique where you don't want to come into the left, into the main branch to distort the brain in the main branch stent also. Next. And we all know that the balloon comes out easily. Next, next. Yeah, so the jail balloon is never a problem. It usually comes out, and you've never had a problem of trapping of this balloon. Next. And you can see that this preserves your side branch of the diagonal well. And we have work to do in the LED with the post dilatation of the LED stent. Next. So we took a high pressure balloon. This is a 8 atmospheres, 8 millimeters balloon, a 3O into 8 balloon. And we went to high pressures almost at 18 to 20 atmospheres to deploy the stent thoroughly. We came back with an IVUS, and this was the tightest part where there was calcium. And you can see this on a stent boost. We saw that there is calcium which is really not expanding here, but the balloon opens on the other side of the vessel. And we said, well, let's look at the imaging to decide whether we go more aggressively in this artery. So an imaging again was done post stent deployment. So can you show the IVUS images? Dr. Srinivas and all the other colleagues, you're free to butt in and give any comments if you have during whatever we are speaking.
Yeah, please go ahead.
So this is the IVUS, the distal landing zone. You can see that it's a well opposed stent. No distal edge dissections. There's a bit of lag of the images. So what I will do is just show you the bookmarks that you've taken so that it becomes easier. Yeah. So this is the bookmark at the calcific areas, and I don't know if it's, yeah. So you can see that this is the calcific area and this well expanded stent there. Okay. So here you can see that this is the area which is expanded. The MLA is almost 5.7, and this is a well expanded stent there. There was one area of under expansion. Just go there and show that other bookmark.
Yeah, the calcium.
Yeah. So this is an area of, this is again an expanded area with an MLA of 6. I'll just show that unexpanded area. Next. So we again went back. So there's one area, this was looked the tightest, and I can't see there. Okay. 5.74. Yeah. So there was an angiographic sort of, I'm sorry, the IVUS images don't seem to be going on well to be, I mean, transmission does not seem to be showing it well.
But
So
we are able to
stuck
see
with
the
two
area
things.
as well. No?
Yeah. Now, the two things that we need to worry about, whether we really need to go more aggressively to expand the stent and correct a malapposition. It's not an under-expanded stent. It's basically a malapposed stent, which I think we all agree would never get apposed completely because the calcium will prevent it from apposition. As long as you don't have an under-expanded stent, I think we're okay with the clinical events. It's important for us to again do an RFR to demonstrate that you have a distal value of more than 0.95 in all these trials that have shown the deferred PCI trial also has shown that you have to have a post-procedural RFR value of more than 9.5 to say that you have had a successful procedure. In case we find that it's more than it's less than 0.95, then we may really think to go back and do a more aggressive dilatation there at that unexpanded area. I would not say unexpanded, but the malopposed area with a high pressure opium balloon to crack that calcium there. Any thoughts there?
Yeah, that's fair enough.
Absolutely.
I think,
Absolutely.
Yeah, so we have the wire of the RFR in the vessel, and I think we can go live and do the pullback. So we have the RFR wire there, and can we have the display of the RFR balloon? Okay, so you have the value there. It's at okay.
There's a question from in the chat box saying that when.
So what do you think?
There's a question which we
discussed more aggressively.
The chat box when you're putting the balloon besides the stent, will it be a problem to get the balloon back? I think you already told it. Balloon never gets jailed there because it's a smaller size balloon. It comes back easily. There was a question in chat. I thought I would just.
The only thing is you have to make sure that you use an NY balloon. Do not try to attempt this with a reused balloon because that can cause problems to you. Yeah.
And one more thing is here, the proximal to the stent segment, there is a mild disease of LADA, which we didn't want to address because it's only milder. So the mild plaques could get disturbed when you're handling it. So we need to handle pulling back of the balloons and other things carefully.
So we're going to go with a pullback here. It's at 0.9594 in the distal LAD. Let's do a pullback to see the value. So this is inside the stent. I'm not able to see balloon. Yeah. So here you have a step up of 0.96 here. And of course, as I said, we come to the proximal LAD or at 0.98. And of course, this is okay. So I think we are happy with the result, and I'll just give an angiographic final result.
Final picture, right?
GTN. Lightroom. So I think this case was interesting, and Dr. Mondal is here. I think he can give his thoughts also. I think this is a case where I think imaging as well as your physiology was important for us to decide what to do for this lady. Without the imaging or without the physiology, I think we could have either overdone the things, probably put in too many stents, or probably. Yeah, so this is the final result. You can see that there's a well-expanded stent in the mid part. The diagonal is flowing, and I think I'm pretty happy with the result. Any comments?
Perfect, Aftab. Congratulations. Showed it effectively not to make things complicated and supported by the imaging as well as physiology. And finally, what matters also is FFR values also came out well, RFR values came well, and the pictures look good both on IVUS and FFR. Congratulations for excellent demonstration. And if there are no further comments from anybody, we'll go to Mumbai. Any final?
Absolutely, Dr. Srinivas. In this case, it's when we have a diffuse disease, I think spot stenting is the way to go. I think the rest of the thing should be managed medically. Absolutely right. The image as well as the FFR clearly showed us the path, to stent only the middle LAD rather than converting it to a difficult scenario of distal left main bifurcation. No doubt.
Okay, bye.
Thank you for the wonderful case. It was a wonderful
Thank you
case.
for excellent demonstration. Bye. Thank you. Can you tech team? Can you connect to Mumbai now? We'll see the final results of Mumbai. Yeah, Rahul, we are with you once again. Rahul and Pillai, sir, we are with you.
Can you please unmute? Can you hear me now?
Yeah, we can hear you.
So what I've done is I've crossed through the strut, got crossed easily and dilated the LCX and did a kissing. I'm just doing the final part and then we'll take an OCT.
Bus. That's it.
Yeah. Okay.
It is very important to take a shorter balloon so that it doesn't project back from the center segment. Also, doesn't go too distally. Sometimes it is challenging to have such short balloons, bigger diameter. I think 6 and 8 are savior. Sometimes they're available.
Yeah, 6 millimeter is a real.
We unfortunately did not have a 6, so we use an 8. And this little overhanging of the balloon is there. I wish I had a 6 or 8 from Abbott.
8 is still fine, Dr. Pillai sir.
Yeah.
So it did fit well, but yeah.
Many other times we think that part will might create more trouble to L6 ostium, but we have seen many times the branches open up well after the part because the side cells of the stent to open up better.
Yes,
absolutely. I think just a bit into the polygonal area, and then you dilate properly.
Small, just 1 minute. Let me take out this. So I'll do an OCT now and take the final image with that OCT. And then if there is further more optimization, we will do post.
What almost always facilitates a better, entry into the LCS, no doubt.
Yeah.
Want some nitrogen?
Oh, there's still, I think, pinching is still there.
No, but many of the times angiographically it might look, but you also image once before you decide.
Yeah. Should I do an FFR across the LCX?
Yeah, that's also okay.
In my experience, if the dye clearance is exactly same for both the vessels, consider that it is FFR negative. We will do a FFR in this case to be sure about it.
There's still some pinching is there. So what is the suggestion? Should we do an FFR or directly do some? I dilated it with a 2.5 balloon at the nominal pressure.
You already dilated LCX ostium?
Yes, that's what I'm saying. LCX ostium has dilated, it has recoiled back.
No, many times. No,
Take a RAO view, take a apicaudal or RAO view. Just look at the ostium again before deciding, to do anything.
Yeah,
I think you should leave it. You should leave it.
Yeah, even I think so. It's not.
You should leave it. I don't think you should touch it now.
Okay. Even FFR, I think, is not needed.
Yeah, that's fine. If you do an OCT in the bifurcation mode, you see the circular opening of the LCX very well.
Let's do a bifurcation mode OCT.
If they don't have struts across, that's supposed to be good. No fibrotic bands will form. And or I've already done a 2.5 balloon. I think will be separated out from the ostium.
This is the one as that. Give the OCT, please. OCT. Where the wire has come out.
We have only few minutes left, Rahul.
I'll try to this. Somehow this wire has come out.
It doesn't want LCX to be done anything. God is saying you better remove the wires.
I'll put this.
Put that. Show the flow.
I'll take it out.
Yeah.
You need not go into you can go into LED, just take a OCT picture.
Yeah. I'll take a bifurcation view OCT.
Yeah. I keep telling in my lab like this, whenever the God doesn't want you to do anything, these things happen.
Yeah, very true. Very true.
Very true.
My colleagues keep telling inadvertently you don't want to do it. That's how you make it come back and you say that God doesn't want. But anyway, finally, the result has come out excellent. Great demonstration of a critical case.
It was a wonderful case, actually.
And how to tackle. It's also important to see the distal extent of the stent catheter OCT to be passed beyond that, so that
I will go beyond the distal stent and then see.
And then come back and image both left main and the aneurysm portion.
Yes.
Need to optimize the LED. No?
Yeah, we'll optimize the LED after this. We'll see the OCT. We just show them and then post that we can post.
Let's see, we'll decide.
Can you go to the cranial view? Can you please connect the camera to the OCT thing? Give me the die.
23 die. Oh, yes, no?
OCD को connect. Yeah.
Yes, introduce it. Yeah, that's fine.
Okay.
Touching this.
Are you ready? Please enable the pullback.
Excellent.
Very well expanded strength.
Take it out.
I think the results are looking great, so we take a bifurcation view also. Take it back.
Yeah, it looks good.
I think
Yeah, it looks very good actually.
we have come to the
Aneurysmal area, right? No, it's coming.
Yeah, so
Yeah.
L6
Osteum of
also.
L6 is good.
Yeah.
Yeah, L6 osteum is good. I don't think we should touch it.
Okay.
Considering the anatomy, aneurysm, it has very well expanded stents actually.
Yeah, I think the results are looking good, well expanded. We can see the, the stent is looking quite okay. You want me to do a bifurcation view, this thing?
Yeah,
high
we
resolution.
We do that.
I mean, the same thing, it happens. Just go to click on the bifurcation view and it shows the.
Yeah, that also. Just go to the bifurcation view. Show that area.
Go to the LCX. This is a branch of.
Go to the LCX osteum.
LCX osteum, please.
LCX. Come proximally.
Yeah, that's a place.
Yeah. Just rotate it. Just rotate. Rotate the image. This side.
It's very important not to get carried away. Sometimes it looks like underexpanded. But
It's the thing. It's circular. It's little oval, but I think it's okay. It's looking quite
perfect.
okay.
No struts across.
No
Also.
struts. Yes.
I think
no struts
that
across.
is very good. And thanks for excellent demonstration of a complex case. I think a balance of a very senior physician, Dr. Pillai, with aggressive interventional cardiologist Rahul helps us always to balance out things. And sir was telling that in his experience, L6, that is flowing well, it would be all right. That's what came out even in osteum. Thank you and great case demonstration.
Thank you very much.
Rahul and Pillai sir for demonstrating tough case in the tough COVID.
Thank you.
Thank you, Gopal Murugan.
Thank you for the wonderful case, Dr.
Srinivas.
Yeah.
Thank you, sir.
Thank you.
We'll break and now we'll go for the talk here. Thank you. Can you cut off the live feed from Mumbai and we'll have a presentation. Normally, I wouldn't keep any presentations, but I wanted to take this forward, these concepts of we working together. That's why I've selected only one talk. I will take 10-15 minutes of your time and show across about the 2 or 3 research protocols and some registries which we want to make. And we request all the cardiologists from the periphery. I see Dr. Barua, Dr. Sarita Rao, and many others will be joining. Thanks for joining. Thanks for all the cooperation. I would share my slides. Give me 1 minute.
Please click on the share screen, sir.
Can you see my slides now?
Yes, sir. We can see your screen, sir. Good to go, sir.
Okay. Thank you. Thanks for all the colleagues across Apollo, and thanks again. This was my wish and desire to have such sort of meeting, and everybody cooperated, and we had great case demonstrations from Mumbai and Kolkata, and exactly showing what needs to be done with these patients. What the thing I've selected is to present. Actually, many things could be done, but I selected 1 or 2 important protocols and 1 or 2 registries. Hope I'm audible and clear. And for
You're
the
audible.
sake of anything, and I will briefly take you through. And this is what we're trying to network across, and I'm proud to have these all colleagues from various hospitals of Apollos. And I'm always proud to present my fax professional service colleagues. We work like a hub and a team, and in tough COVID times, it has been really helpful. And also to get patients for high-end imaging procedures or TAVR procedures, this goes a long way. And we are always working as a team, though our colleagues work in various other hospitals was mentioned here. But Apollo works as a hub with spokes and all across. And this has been appreciated by European Heart Journal. Some of you must have seen this, but I always take pride in showing this. And Apollo, Sangeeta Madam and everybody was also very happy. My other colleague, Dr. Gokul and Dr. Avibatin, are also part of this publication in European Heart Journal. I always feel that this is the way to go, to have a group practice and do what is best, and also have a work-life balance for all the colleagues. It's also good to have collaborations with teams abroad. And we're very fortunate to have, I think, Sushil, Ajay, in spite of all the busy schedules, they logged in because of this. And FACS, we are collaborating with Columbia and run this TCT program. I think this man you all know is Dr. Leon, and we are fortunate to do some live cases along with him. And this Dr. Sushil Kodali, I should pay my special regards and thanks for establishing a TAVR program in the main Apollo. He has came here initially and learned a lot of things. And then other thing which we take pride in doing it is the collaborations, how it helps. I just want to show it as inspiration to all others. With Edwards and Columbia, FACS and Apollo together, we run this project for poor pregnant heart women patients. This got published in the Edwards Heartbeat Matters newsletter across the world. And this is Dr. Amisha Patel who coordinates this as a Columbia faculty. It's me. And we done a poor PBMV patient, everything done free. And the screening of this also gets done in both in Gandhi, Usmania, and some of these private medical colleges, and it's taken care by this Edwards partnership. Coming to research presentations, there could be too many, but I've selected the important ones. This have been my passion again before QFR, Favor India trial. I've been always trying to see how best to avoid unnecessary procedures, at the same time do what is right for the patients. And this is QFR goes a long way in doing patient thing right. Many of the times FFR again needs a special wire and other problems. If you can get all the information with the same angiographic views, it was best. So I was passionate about this since last 3-4 years, and now it is coming to real practice. Now the new GE lab which we have, we are trying to get the software installed, and FACS Core Laboratory is acting as a reference core laboratory for this Favor India trial. Apollo, KIMS Care, and Covey Medical Center. As we know, stenosis, whether to do it or not, we decide by FFR. But this QFR modality is by taking it to 25-degree different views. You have a computer reconstructs a 3D-dimensional artery and gives you FFR values at any particular point of time. And the other beauty is you can actually scroll through at each point, whatever the value you want, you can get it like how we have it in RFR now. And this is how we calculate the QFR value only on angiographic basis, and also 5 French catheters pictures are also good enough, but you need to get a good angiographic pictures. So Favor India protocol, Favor means the online quantitative flow ratio functional assessment by virtual online reconstruction, and we plan to recruit about 300 patients. 36 patients were done before and COVID stalled everything. What we need to assess is the sensitivity, specificity of QFR and FFR with positive and negative predictive values. Inclusion criteria of stable patients or culprit vessels in MI. Exclusion criteria is all mentioned here. I won't go into details, but angiographically borderline lesions of 30 to 90%, reference vessels of more than 2 millimeters, and other poor parameters of aorto-osteal lesions, other things are exclusion criteria. So basically, we want to get these values like this, and then we are passionate about this, and we did live demonstration in TCT. Even in that, we were surprised to get this almost the same values of both. Even live transmission, everything gets reconstructed in 5 minutes online, and we got similar comparable values. We wish all our colleagues could contribute patients, and all of us who are planning procedures for FFR, they can be included. Only thing is we need to take 2 angiographic separate views, and then probably FFR values you you can keep it, and QFR analysis, you can send those pictures for the analysis to us. All this can be done online. That's another Favor India trial. We wish to contribute significant amount of patients. We request everybody's cooperation on it. Other research protocol which is important is many of the times we see lipoprotein small a is important in an Indian subset of patients, and we do see some patients with high lipid levels when their lipoproteins are done, values are high. This is horizon trial study, basically is a Novartis sponsored study. What it tends to do is patients who have very high CVD risk factors and even documented CVD who has LPA more than 70 milligrams. This is quite high value, but that's what the trial is selected because probably it needs to get into lower. This is injection. This is once in a month mRNA injection. It's like PCSK9 injection once in a month, and then probably it's a huge multi-center trial, 7,860 patients. Just got approval in ethics committee in Apollo. The previous one, Favor trial is already done. Approval is done and recruitment is on. This, I think, probably would be able to start recruitment from next month onwards. These are the two important trials which are on. And when I was fortunate to be NIC chair, this is what we did in 2018. We proved Apollo as the highest volume operator and stands tall above all other centers with 19,681 PCIs, contributing about 55% of the total volumes of the country. But this all happened with 15 centers together when we analyzed from the NIC point of view, the data together. Others have been much behind with 15,000 plus PCIs. I did try to recommend and see that Apollo Cath registry. I made it prepared, but failed miserably because contributions and entry is not happening. But I again request everybody, probably whoever is interested, can take this forward and have the entry of the each centers. Now, what I definitely want to do is this Apollo TAVI Tower registry. This is again, as we discussed yesterday, if we club all our data together, we would have been the leading TAVI center also in the country, which we are not now. So, but if you have 50, 60 from here and 50, 60 from Chennai, all of them together, we would have had to be in the #1 unit in this TAVI registry. Also, we made a very simple TAVI protocol for registry for entry. One is that we wanted to show this live, but this Apollo MedMantra system doesn't allow external access. All of you who have MedMantra passwords can go into MedMantra and click on this TAVI registry button. And then you get initial patient details, all the standard ones, and then echo parameters. What is very important, the bicuspid, tricuspid nature of the valve, and the LV parameters also are important, and annulus measurements are important. These are pretty standard, but quite easy to enter. We didn't want to make it too much complicated also. The CT angio parameters are important. Morphology, again, many of the times deciding on the annulus size and coronary heights, what we all standard, and femoral axis diameters, and the TAVI procedure details. So it would not take more than 5 minutes to enter the data in this. We request again to take this seriously, and whoever is part of it. What I also requested management is once the procedure is done, the techs can enter it, but I request all the colleagues to allow that to happen. So that's about the TAVI registry. We should be doing it. In NIC, we collected about 500 plus patients, happened in 2018, and it has increased to 650 in 2019. We don't have 2020 data yet. And in Apollo, probably we have done about 58 cases. So most of them have been core valve, self-expanding 39 I'm talking about Health City, Hyderabad, and Edwards, and 12 and 7 of my valve. Some of them are done by my other colleagues too. And most of them are high risk, and mostly were more than 65 years of age group. We had very good success rate. And this is quite encouraging for all of us to get patients improving dramatically after the procedure. Sick patients, heart failure dependent, improve dramatically with this procedure. I request all of you to take this pathway seriously, registry, and then probably cooperate in entering the data. Then coming to ACS pathway, where every hospital of Apollo can contribute here. This is again being done already in Jubilee Hills Apollo Health City. And we were, with COVID times, we went into difficult times, and the door to balloon times were significantly increasing. Then all of us sat together. I should especially congratulate our Apollo operations team and Tejasvi heading the operations, and many other quality departments, and ER consultants, and ER head now Tamarish, who actually was quite helpful in organizing this meeting, and all the cardiologists, especially my younger cardiology colleagues, Dr. Sanjeev Kumar, Dr. Ramkrishna, many other colleagues who actively stay in the hospital And also our FNB students and the DNB students also help a lot in decreasing the door to balloon times. And the heart team approach is leading to further better outcomes. We have collected about this is the ACS activated pathway, about 288 patients. If you see it here, somewhere in between June, July, August, September, the worst period because of COVID, decreased, and gradually it is now trying to come back and improve numbers. And the age groups of this probably is 50 to 70 is the commonest age group. We also see some younger patients, and gender, most of them, 75% were males, as seen in many of the studies. And most of the patients of echo had, most of them were having moderate or mild LV dysfunction, and some of them had severe. This is what I wanted to highlight. The door to balloon times initially were okay. We were favoring around what is recommended. This cutoff value is about 90 minutes door to balloon times were recommended. Slightly higher, we did improve before, but this COVID, it became haywire, it went very high. So we wanted to come back, and that's where we were wanting to discuss. And the operations team came back with these pathways. And I'm very happy to say that once the COVID cases decreased in January and February, we had about 24 cases and 34 cases, the door to balloon time significantly less than what is recommended, about 49 and 44 minutes. Just to take you through what has happened yesterday, this is 19th March. Yesterday's case, 27-year-old male. Unfortunately, we do see very young patients like this, presented with interval changes. I have actually highlighted the timings here. This is a sheet which are used in Apollo. Arrival time is 8:20 a.m. Patients of primary PCI is done and then comes out at 9:40. So that's how it is quite encouraging to have very less time, short time, tight lesion is ready, and post-dilated. Dr. Sanjeev, my colleague, did this, and patient did all right. And then that's how now we all want to come out with this Apollo Cardiology Consultants Consortium. That is, we pledge all of us to decrease these door to balloon times further to less than 1 hour, especially in these post-COVID times. If all of us are together, I think this can happen, and this can spread a word that of appreciation that all of us struggle hard in these tough times of COVID. And I'm very happy again. I don't want to take too much time. I wanted to save some time also. And some of the other newer research protocols which we're working on is something on artificial intelligence, where the artificial intelligence is used to see by the routine CT scans, which are done for the COVID patients, whether calcium can be identified with using artificial intelligence. And also now the calcium score on the aortic valve, TAVR patients, whether artificial intelligence can help in it. These are one of the things which are being done apart from some of the drug trials regarding ARNI and other things which are going on. I think with this, I'll stop, and I'm happy and request all colleagues to take this seriously and help us in building up these registries and data across all Apollos. Thank you very much. And if there are any questions, I'd be happy to discuss. Otherwise, we'll go on to the presentations. I need to stop sharing, I think, no? Okay. Can we get the gallery view where all the colleagues can see each other? I think any comments or questions from any of you? I see Barua.
Yeah, I think it's a great initiative, Dr. Srinivas. I'm very happy to see that. I know the year after the academics always. I think I have been thinking. I've been even telling many times. Many years back, I requested my manager, and when I spoke to Madam also once, the need to have our own data registry and all long back. I think it's not being fulfilled or not materialized because of various reasons. Now we are taking initiative. I think it's a great thing because, as you know, as a Apollo group, we have a maximum number of cases, all complex cases, new cases. Everything is being initiated in Apollo itself. It is a great initiative. I hope we'll be able to achieve the kind of show us. This is one of the best group in the world. And we are always there with you. And any help, any kind of required, I'm always there. And we'll try to upload and try to help in this kind of fulfilling this kind of your idea and your kind of targets. All the best. Thank you very much.
Thank you. Sarita Madam, I see she actually requested me to have a live slot for her, but because of obviously you can't have live cases from everywhere, so I requested her to show a case and probably we could involve more in future. I see Sridhar, I see Rajeshwari. Anybody?
Namaste, family. Namaste, Apollo family.
Good evening, madam.
Good evening.
Good evening, Dr. Srinivas.
And thank you for having me here. And it's wonderful, all the work that you are doing. It is very impressive in spite of the fact that you're so busy. You still have time for all of these things. It's wonderful. All the registries, all that work. Excellent.
Thank you. Sridhar, you want to say anything, or shall we go for the
nothing,
last?
Sir, it was very good, very good. No, any of that registry also good, no, sir. So numbers were increased. Even the COVID time, I think in Hyderabad we did more cases.
Yes, yes. Thank you. All happens because positive work of all the youngsters who stay in the hospital. Thank you. I think if there are no further questions on this, I think Sushil might come back for his lecture. We'll go for last interesting cases session. I think other colleagues, Dr. Subro Banerjee, our senior cardiology colleague from Kolkata, I think he has already joined. Dr. N.V. Raidu, sir, Dr. Badrinarana, Dr. Jay Rangnath to be chairing. And anyway, we are all one family. Other panelists, Rajeshwari Madam has joined. Ravindran is there already. Dr. Panigrafi, Dr. Rakesh Gopal, Kadiresan, Arun Srinivas, feel free to join and probably pass on your comments in between the cases. And with this, we thought we'll have some interesting cases from the various other centers of Apollo. And we also have pediatric cardiology colleague, Dr. Kavita Madam always gives that touch for the children. And we wanted to show, requested her to show some case. It's post-Glenn cyanotic child management. I think, welcome, Dr. Kavita Madam. Over to you for your presentation.
Thank you.
Before it starts, anybody wants to say any few words, or we can keep talking in between? Go ahead, madam.
Thank you, Dr. Srinivas. Pleasure to be here, and he's always kind enough to include a little bit of child perspective. And nice to know about the Connect conference and the collaboration that's going on. So I'll share my screen. So this is an interesting case I did recently. It's a cyanosis post-Glenn. For those that are a little away from congenital heart disease, just wanted to show a slide about the Glenn procedure. So it's basically a second step of the single ventricle pathway where we connect the superior vena cava to the right pulmonary artery. And if there's a left superior vena cava, it's going to be a left pulmonary artery to left SVC. And it's bidirectional because it flows to the both pulmonary arteries. And then the next step, as you all know, would be a Fontan tunnel. And in Apollo, we've done more than 150 cases, and most of the cases have been extracardiac Fontan. So this is a child who's an 8-year-old boy with complex congenital heart disease that I will go over. And he presented to the clinic actually after several years of being lost to follow-up. He had his first step of cardiac surgery, which was bidirectional Glenn at 1.5 years, and subsequently did not show up. So when he presented to the clinic, he presented with shortness of breath on exertion that has been of a gradual onset for a few months to a year, and then worsening of his color. So this is his anatomy. He had dextrocardia with a common AV septal defect, which was dominant left ventricle. So the right ventricle was hypoplastic. And then he had a double outlet right ventricle with L Malpos great artery. So the RV gave rise to both the aorta and the pulmonary artery. There was severe pulmonary artery stenosis. He had an absent right SVC, and he had a left SVC that drained into the coronary sinus. So this was his native anatomy. And then after that, he had a left bidirectional Glenn. So his left SVC was anastomosed to the left pulmonary artery, and there was barely any flow antegrade anyway to the pulmonary artery. So this is his current anatomy, and he has a connecting vein. On clinical assessment, he was deeply cyanotic. He had clubbing. He weighed about 22 kilos, and his cardiovascular examination was showed a single second heart sound without any prominent murmurs. His vitals were stable. He had sinus rhythm, and his saturation at best was 72%. So anywhere from 70 to 72% was his saturation. And his hemoglobin was 19 grams. The rest of the routine labs were all unremarkable. So his echocardiogram, I just have a couple slides. So it's a dextrocardia showing and a common AV septal defect, a hypoplastic left-sided right ventricle. there was a little bit of AV valve regurgitation. And this is a suprasternal view showing the glen and anastomosis. Actually, this is ascending aorta. This is the innominate vein. And actually, he had a left SVC, which is, so he had a left superior vena cava to left pulmonary artery, which is not shown in this picture patent. And then he also has this flow on the right side of aorta coming from his right internal jugular vein, which is normally the location of right superior vena cava, which should not be there, according to what he had done. So I took him to the cath lab, and these are the hemodynamics. The superior vena cava pressure, which is also equal to pulmonary artery pressure in a glen circulation, unless there's some pulmonary artery obstruction. So it was a mean of 8. And then the right atrial, left atrial pressures should be similar if the ASD is non-restrictive, which was 6. So his transpulmonary gradient was basically 2. So from SVC to RA is his transpulmonary gradient. His left ventricular end diastolic pressures were normal, and we took a run of pulse oximetry. So his QP is calculated as 1.95 liters and the QS of 5.6. So almost, QP was less than 1/4 of his systemic cardiac output. Pulmonary vascular resistance was calculated at 1 Woods unit. So then subsequently we did angiography, just to mention the management of a cyanotic child post-glen. So in a glen, the QP-QS is expected to be 0.6 to 0.7 because the systemic venous blood from the upper part of the body is going to the pulmonary blood flow, and then the inferior vena cava is still going into the heart. So expected QP-QS is 0.6 to 0.7, and saturations we normally expect around 80 to 85%. That is a good glen. So we follow these children in the OP, and anytime the saturations are less than 75, it is considered as excess cyanosis for the glen children. So the main reasons for this cyanosis would be top number 1 would be veno-venous collaterals, and these could be from various areas of the superior vena caval system. So either the SVC proper, azygous, hemiazygous, brachiocephalic vein. So they originate anywhere in the superior vena caval system, and then most of the time they go into the infradiaphragmatic area into the inferior vena cava system. So this is thought to be because SVC pressures are higher to maintain the pulmonary blood flow, and then the IVC pressures are lower. So this transpulmonary gradient is what is the reason for opening up of collaterals. So these are collaterals that are opened up, means the embryological veins open up because of this pressure difference. That's one hypothesis, but we've really not understood very well why these children develop venous collaterals. They can develop either before the BDG, most commonly after the BDG, and sometimes we've even seen them get these after Fontan operation. The second reason for cyanosis in these children would be a systemic to pulmonary venous connection. So again, the systemic veins can come from anywhere in the glen circuit, and they empty into either the right atrium or left atrium, which is now going to be the pulmonary venous atrium. So it's a direct right to left shunt. And then the third reason we look for is pulmonary arteriovenous malformations. And again, very common to have arteriovenous malformations in these children, especially those with the heterotaxy syndromes or those that have interrupted IVC, because they don't have the hepatic factor, because the hepatic blood flow is not going into the pulmonary artery. They have a tendency to develop pulmonary arteriovenous malformation. So these are the 3 main reasons why they develop cyanosis. So this is a cartoon that shows the various locations of venous collaterals from the right SVC, from the brachiocephalic vein, and left SVC, a persistent left SVC, which is either undetected or has opened up, is a common reason. And then they can enter anywhere into the right atrium or subdiaphragmatically in the IVC. So these are the locations. Now this, coming back to this patient, so we did a detailed angiography. I don't have all the pictures here, but the salient points are, this is an injection. So I took an access in the left internal jugular vein. My plan was to take left and right internal jugular veins because I also wanted to occlude any collaterals to see what the glen pressure would be. So this is from the left IJV into the left SVC LP anastomosis, and this shows a good PA anatomy. Maybe there's a little less blood flow to the left upper lobe, which we commonly see, but there's a patent connection here. And then I could not get the right IJ access, so I took a right subclavian vein. So this is an injection from right subclavian vein into the right internal jugular vein, which is showing a markedly dilated abnormal vessel here that is running down below the diaphragm and ending in the paravertebral plexus and eventually draining into the IVC. So these are all abnormal collaterals. And then this is a wire across the connecting vein between the right subclavian that is going down. And this vessel was identified as the hemiazygous vein. So you'll see an injection. So the injection into this vein, this is the recanalization of the hemiazygous vein, and you can see that it's very prominent and going below the diaphragm. And again, giving rise to venous collaterals in the vertebral plexus. And also, if you notice, some of the blood enters the right atrium. So the way this causes cyanosis is that this is redirecting blood from the superior vena cava into the infradiaphragmatic system. So the pulmonary blood flow in these children is very less. So it's kind of a steal phenomena, and that's why these children are cyanotic. So actually, I wanted to, there's always a concern with these children that with these pop-up of collaterals, the Glenn pressure may actually be high when we occlude these. So we are a little hesitant to occlude these. So I actually wanted to balloon occlude both of them and see the Glenn pressure, but because I just had 2 venous lines, because the femoral doesn't go into the Glenn system. So all I had was the subclavian and the IJ veins because I couldn't get the right IJV. So I decided to occlude the left hemiazygous vein with a vascular plug. So I used an 8 millimeter diameter by 7 length AVP2 to plug this. And the access I could get across was only through right subclavian. Again, the wire from the left IJV would not go into this hemiazygous because of the acute angle here. So this is post-occlusion, and you can see again, after occlusion, there are small other venous collaterals coming in, which is very common. So these children have multiple collaterals. It is often impossible to, kind of occlude all of them. So we target the big one. So this is showing good occlusion of this left hemiazygous. And then the next was to enter the right, enter the azygous vein. So this bigger vein that I showed in the previous angio is the azygous, and then I wanted to balloon occlude this big vein and see if the Glenn pressure rises, which actually surprisingly this child's pressure in the SPC was not very high. With these sort of collaterals, I was expecting it to be high, but even after balloon occlusion, which I left the balloon for about 10 minutes, and then through the left IJ, measured the Glenn pressure, and there was not much rise at all. Maybe a 1 millimeter rise was there in the Glenn pressure. So then this would be suitable for occlusion. So I used a 10 mm by 6 mm AVP2 and plugged this in the proximal area. So blocking the blood flow down into the IVC, which would be the which would enter the heart. So then this will encourage more of the blood to go into the pulmonary artery, and thereby the saturations are expected to improve. So the baseline was 72%. With occlusion of hemiazygous, the saturations went up to 78%, and with the second occlusion, they went up to 82%. So this was a good result. And then there were some smaller collaterals which we could not occlude because of the time it takes for these. So so the result was good. We had no complications, and so in summary, whenever we have a child presenting with Glenn with saturations less than 75%, a detailed hemodynamic and angiographic assessment of patient is very important. Actually, sometimes they present with severe desaturation immediately post-Glenn, and that can be really catastrophic. So we often, in a post-operative child, especially if there's desaturation, we do take them to the cath lab and have to deal with all these collaterals immediately. So apart from venous collaterals, we look for systemic to pulmonary venous shunts and pulmonary arteriovenous malformations, which this patient did not have. And these venous collaterals can contribute to significant hypoxia both early and also late after Glenn. So anytime between the Glenn and Fontan, they are very significant and cause hypoxia. Now, when you want to do a Fontan, then both the inferior vena cava and superior vena cava systems will enter the pulmonary artery. So these collaterals doesn't matter after Fontan. Then so interventional treatment of venous collaterals can be done and can significantly improve hypoxia in these children. Thank you.
Thank you, madam. Thanks for showing an interesting case. We request all the speakers to stick to time because we need to have also Sushil Kodali's talk in the end. I saved some time, which Kavita madam took it away. That's fine.
Sorry,
I think.
Sorry, did I exceed my time? I'm sorry. I don't have watched it.
That's fine. The pediatric explanations take some time. I request other colleagues to stick on to the 10 minutes time of presentation because I requested Sushil to give the talk in the end so that all of us would hang around without going away to watch IPL. So I think any comments from Dr. Subro Banerjee sir or Raidu or Badrinarana on this? Or will proceed for
really interesting presentation and the practical. Many children usually come to the OPD timely intervention maybe save some lives of the children. Madam really simplified the and given outlook how to go with the post-Glenn cyanosis childs. Thank you, madam, for a nice presentation.
Thank you, sir.
Can I ask something?
Yeah, madam.
Dr. Kavita?
Yes.
Do you usually do cardiac CT at all before planning the intervention, which will give you more?
Yes. Sometimes we do, especially when you want to choose, be ready with the devices. Now, if your cath lab is not equipped with everything, it often helps to choose your device based on the CT.
Madam, woman empowerment in cardiology is happening too much. It looks like a lot of colleagues, aggressive work in interventional cardiology also. Dr. Sarita, madam, all of you make us very humble. Anyway, we'll proceed with the next presentation. Dr. D.K. Barua from Apollo Vizag. He has a lot of experience with these IVL cases. We've been selecting the talks. I've been always trying to see who has the maximum exposure in that, and that's how I've selected this. And Barua, I think in Apollo Group, has done maximum cases with this IVL balloon. Over to you, Barua, and show your interesting case experience with this IVL new technology for calcification approach. Please stick to your times, please.
Is it visible?
No,
Yeah,
not yet.
visible. Yeah, go ahead.
Huh? Visible, huh?
Is it visible?
Yes.
No, it's not visible.
No, slides are not visible. You are visible.
Yeah, slides are not visible. That's what I'm. You stop sharing. Kavita madam, did you stop sharing?
Stop sharing? You have to stop sharing it.
Yes, sir. Everyone has stopped share, sir.
Okay.
Barua, sir, please click on the share screen button, sir, and open the PPT, sir.
Is it visible now?
Yes, sir. It's visible, sir.
Make it
you can put it in the full slide mode, sir.
Is it so?
Good, sir. You're good to go, sir.
You can see now?
Yes.
You can see now.
Yeah. Good evening to all. Thank you very much, Dr. Srinivas, for giving me this opportunity. All of us know that calcium is a challenge in cath lab, and especially, difficulty in crossing the devices and under expansion of the stent and perforation. So many, difficulties we face. All of us very familiar with that, and we have all this armamentarium to treat calcium. All of us familiar. And this is the new tool added to this armamentarium. And as I told you, acoustic pressure wave, which works as a very good kind of treatment for superficial deep calcium. And it can even effectively it can generate pressure up to 50 atmosphere, which is great to crack the calcium in the deep as well as superficial. We have done about 20 cases we have done so far, but we have analyzed total 16 cases. These other cases not yet analyzed. Total number of arteries were 17. Mean age we have 69, around 70 years. Diabetes, as you know, hypertension is the commonest. Diabetes is 37%. We have a femoral excess of 18%. Post-CABG 2 cases, and LV dysfunction we have over 31%. And total number of arteries, left main we have done 2, LED 9 cases, circ 3, and RCA 3 cases. One complement as a rotablation was a complementary in one case, and we had a giant aneurysm of the LED which was calcified. We did that with IVL followed by stenting. And if you presentation of the cases, STEMI 2, non-STEMI, unstable angina 8, and stable angina 6 cases. And you see the mean lesions, stenosis at 83, quite a significant lesions. Mean lesion length is again, as you know, is a complex lesion, 35. Mean MLD was 0.9, and mean IVL pulses was 7, and mean balloon diameter was 3.12. And procedural outcome, mean residual stenosis 8, which is not bad actually, in a calcified lesions less than 10%. Mean MLD post-stenting was 3. Average number of stents were used 1:1.8. Mean stent diameter is 2.98. All cases were successful. Only one case is a coronary dissection, significant coronary dissection can be which was tackled with stenting. And there is 30-day wait cases we analyzed. There is no MACE at 30 days. This is a 83-year-old man, hypertensive. You can see there is a calcified lesion proximal as well as mid, and this lesion was we tried to do the OCT, which could not be crossed. Even with the Godzilla, we could not cross. It was such a heavily eccentric calcified lesions. This is the balloon 2.5 non-Nancy balloon. This was 18 atmosphere. We have gone up to 22 atmosphere. You can see, and with a body wire, this was with a body wire. We've gone up to 24 atmosphere. You can see the waist is a very heavily focal calcified lesions, which is very difficult to crack with a routine balloon. And finally, this is the actually IVL balloon 3x12. Again, it was difficult to cross. As you know, IVL balloons are a little kind of bulky balloon and stiff balloon. So we have to use again kind of Godzilla catheter to cross the lesion with this, and which is able to cross this, crack the lesions here. You can see that. Finally, we put a stent here, and you can see the calcium crack here. And final result was acceptable. You can see here this lesion was well open, and we done OCT. OCT shows well deployed stent, and a patient, I think now 6 months over, is doing very well. And this is another case, 65-year-old hypertensive male presented with a class 3 angina. You can see there's a calcification of the LAD as well as circumflex, very complex bifurcation lesion of the circumflex as well as bifurcation lesion of the left main. And we did actually balloon dilatation. I could not show that, but this you can see the balloon dilatation could not crack that. This is the IVL on third. This is the third pulses. A third pulses also, it was waist was there. Finally, it given away. We could open that with the IVL balloon. You can see this is an OM and third bifurcation. There's the LAD. And finally, we use a first bifurcation, or third and OM with a minimal cross. I feel more comfortable with this. You can see that OM stent was deployed, followed by it was crossed with a bigger stent in the circumflex. And finally, we did the kissing, which I'm not able to show because of time factor. And second, we did LAD opening, but the LAD was not that great. Initially, we thought we leave the LAD, but after opening the ostium, it was not looking good. That's why we thought we'll go for a LAD stenting. It was done with a minimal cross, or you can say the nano cross. A very small part of the LAD was there. We could cross with another balloon in the left main, and the LAD stent was deployed. Finally, kissing balloon was done with a pot. You can see the final result was good. This is the first bifurcation, and this is the left main bifurcation. Very sorry, I could not forgot to get the OCT. Actually, it was there today in the hospital, but I forgot to get it. This is the final result with that. And OCT we did. OCT was good. It was showing the good bifurcation, kind of left main bifurcation with a OM also. It was very good. OCT wise also there is no undeployed stent. And left main was more than 11, in fact, so which is very acceptable for the left main stenting. With this, I should conclude the IVL is an useful tool in treating calcified lesions. Advantage is that it can treat the superficial as well as deep calcium, and thus it helps in achieving bigger luminal area, which is very important for long-term result, as well as stent diameter, which is again an important determinant of the reduced target lesion failure. Thank you very much for your kind attention. Thank you.
Thank you, Barwa. Did you notice any balloon ruptures while using this technology? Because we did
I had two balloon rupture, one in the LAD as well as one in the RCA. Two balloon we had out of all these 20 cases, but we didn't have any major problem. Because that is the reason we need to be very careful. We need to make sure that there is no air bubble in the IVL balloon. Another thing I think because they recommend that you go to up to the 4 atmosphere, then inflate, do the IVL, then you can go to 6. I think that 6 part that the balloon can post dilate after IVL. If you feel that it is not required, I think better not to go for that 6 atmosphere post dilatation after IVL. That can be done with another balloon if at all required, because that is the time sometimes you can get the rupture.
I fully agree with you, Dr. Bhatia. That's exactly what happened in our cases also. When you go up to that 6, that's the time that the rupture occurs. So now we've stopped going up to 6. We go up to 4, give the therapy, and then we come down. So that has absolutely reduced the incidence of rupture. We have to remember that the IVL balloon is a balloon for giving the sonic pulses. it's not a balloon which is to be used for dilatation.
Yes,
so we can always take in a non-compliant balloon after that, or whatever you require, and then dilate with that. I wanted to ask you, so have you experienced shock topics in your cases? And what is your methodology for using IVL in a patient who has a pacemaker or an AICD implanted?
Yeah, shock topics always you will see. Most of the cases we see that, but I never experienced any kind of arrhythmia induced by the shock topics. Only we have seen a little bit of blood pressure reduction during those situations, but we never had any kind of significant hemodynamic problems, as well as any arrhythmias induced by the shock topics. I am not sure. I am not experienced pacemaker as well as an ICD patient. I have not done so far. That I think is a good question. I have to think over that. I think we have to go to that. What anything should be done during those cases. I don't have any experience in pacemaker patient as well as ICD patient.
So we did one patient in.
Yeah, the balloon ruptures. When you contacted the company, they're saying they're coming with 2 double-layered balloon for this IVL, like OPN.
Yeah, that's what they told me also. Yeah.
Preventing the rupture, increasing. Banerjee sir, anything you want?
Yeah.
One by one.
Good evening.
Good evening, Dr. Borua, and I think thanks for the nice presentation. My question is what's your approach? I mean, say when you do an OCT and you find there is a moderate calcium burden, and this patient would probably qualify for an IVL, would you normally give some other maybe less expensive devices a try, or you straight away go to IVL in such cases? I'm not talking about extremely concentric calcification, maybe 180-degree calcification, maybe borderline depth, of those cases, those borderline cases.
Yeah, because nowadays we do get very elderly patients, post CABG patients. Most of the patients will have calcification. Most of the cases I get all the mostly elderly and very complex cases. I always avoid to do IVL and rotablation. Most of the cases I try, but during those cases actually I do OCT. If OCT is a very significant calcification, especially deep, and calcium is more than 750 or thickness, length is more than 5, and it is more than 180. Then only I usually use this kind of tools. Otherwise, you do not do that. Most of that I try to do it a non-compliant balloon, or in fact now we have a OPN NC balloon. Even recently I've done 2 cases. Initially I thought I'll take for IVL, but I could manage the OPN NC balloon. So many a time I think IVL can be complementary. Suppose if you cannot do that with other techniques, maybe you can use that. But I think electively, unless I have a OCT, usually by angiographically I do not go for IVL directly. Yeah, on a really heavy calcification and moderately heavy calcifications, kind of significant thickness and length, then only I go for IVL.
I think as Madam is commenting, you can stop sharing, Barwa. Madam, you can start sharing the slides. Go ahead, Madam.
I just wanted to say, sir, from your data, the diabetics are only 34%. Very interesting, because usually we say calcific lesions are more common in diabetics, but I think your data says most of them were hypertensive rather than diabetics.
Yes.
Nice cases, Barwa sir, but one thing, before taking for IVL, any CT coronary angiogram can helpful for decision for IVL or rota, anything? Any literature says like?
Yeah, obviously CT calcium, CT is one of the important tool to detect coronary calcium. Maybe it will be useful, but we have not done that test because of very small numbers. Maybe if you have more numbers, maybe you can think.
If you select for IVL, the costly thing, So you can before taking your IVL or rota or opium bill or anything.
But yes, sir. We cannot decide based on CT angiogram, because CT cannot identify really it is a superficial or deep.
This comes CT says eccentric or concentric, how much everything they can tell, no?
Yeah, it can tell, but I think the intimal and thickness and all will be very difficult by CT, which we decide for this kind of tool by doing OCTs. I think CT cannot give that kind of information, probably.
Dr. Barua, have you tried IVL inside a freshly deployed stent?
Inside, madam?
Inside the stent. Have you tried it in a freshly deployed stent?
Stent restenosis.
One case actually, one case in fact I had to do it because post stenting that lesion was not yielded, so IVL could do the job actually. So IVL with that I think another indication for IVL, sometimes suppose it is a very resistant case, by chance we deploy the stent which is not able to yield with regular balloons and all. Sometimes IVL can be useful. One case I did that.
Most of the times we
So
take
that's
help
an
of
off-label
OPN.
indication. Yes.
Yeah.
So we had a case similar to this, and we took an OPNNC and it failed to yield. So we had to use IVL inside that, and
Yes.
that also works. So that's an
Yes.
off-label
It works.
indication, but
It works.
yes, it can be used.
Yes.
It works.
Yeah, please proceed with the
So-
presentation.
Thank you, Dr. Srinivas. Good evening, ladies and gentlemen, and I will be presenting severe calcific lesions, rota ablation scores at all. Just a minute. Yes. So fibrocalcific plaques, they reduce the vessel distensibility and they impair a full uniform balloon dilatation and subsequent stent expansion. Now, coronary artery calcification is age and gender dependent, present in about 90% of men and 67% of women older than the age of 70. Various technologies have been developed in order to tackle this problem, as we have been discussing. Rotational atherectomy has long been considered an adequate choice for plaque preparation when dealing with highly calcific lesions or even after a balloon failure. However, in larger vessels and in lesions that are not so tight, these birds might not be able to ablate the plaque. And if at all, it only modifies intimal calcification and many times doesn't deal with circumferential calcification. The calcium scoring system, which we have been discussing, is based on the angle, the thickness, and the length. And various technologies depending on the assessment of the calcification and various calcium modification devices are there. So I'll move to my case. It's a 79-year-old female, class 3 to 4 angina, hypertensive. The angiogram revealed a critical calcific double vessel disease. The RCA had a proximal 90% severely calcific lesion, and the proximal LAD had a 90% eccentric calcification. Bypass surgery was refused by the patient. Now the question arises, which strategy to use? Should I use an IVL or a ROTA or an OPNNC? And which vessel first, the RCA or the LAD? Now, right coronary artery was the more calcific, and it looked as it would be difficult to pass either an OPN or an IVL balloon. The LAD seemed to be the easier of the two. So we decided to take up the RCA first with the following options. OPNNC if the balloon crosses, and finish it with that if the lesion dilates. IVL if the OPNNC crosses but fails to dilate. ROTA if nothing goes in. So this was the patient, and you can see this was the left system, and this was the RCA lesion. Just after the guiding, you can see the calcified valve over there. Now a 2 into 10 balloon failed to cross. A 1.2 into 10 balloon crossed, but the lesion remained undilated. A 1.5 into 10 OPNNC balloon failed to cross. So we took the ROTA, and it was a 1.5 burr, multiple small peckings were done. And after that, a 2 into 10 balloon crossed smoothly. We dilated with that. The stent passed with these, and it expanded with a few undilated struts at the distal edge. Now, what was the approach for this under-expanded strut in a calcified lesion? Should we use an NC, an OPNNC, or an off-label IVL has been used with success. So we decided to take the OPNNC when trading off efficacy with economy. And these were the undilated struts at the distal edge, as you can see. A 3 into 10 OPNNC went ahead and dilated the struts. And this was the final result in this particular case. The LAD was stented in the same sitting using a 1.5 into 10, 3 into 10 OPNNC for pre and post dilatation. In this case, the take home was that always the toughest lesion should be dealt with first. Try with the most effective and economical hardware and upgrade if it fails. The drawback of IVL and OPNNC is the crossability, which is the advantage of ROTA with its attendant disadvantages as well. So when embarking on a calcific lesion, all the available armamentarium should be at hand, as it is difficult to assess the best modality unless you don't dive in the coronaries, and not having one will leave you in the doldrum. Nothing seems to be right here in my second case. This was an anomalous left main from the right coronary sinus having a calcified left main lesion. This has failed a month ago at another center in another city. This was the pre-IVL days, and backup was a real issue. So we took a buddy balloon and a buddy wire. A 2 into 10 balloon at high pressure failed to dilate the lesion. A 2.5 into NC failed to cross. So 2 passes of a 1.5 burr ROTA was done. Post-rota, the 2.5 balloon crossed, but the lesion still did not yield with 20 atmospheres of pressure. The stent, however, could go through after dilatation with the 2.5 non-compliant balloon and was dilated, but there was dog boning suggestive of circumferential calcium. As you can see, this dog boning. So we took an OP&NC, it was negotiated, and it was inflated. The stent was finally dilated at 38 atmospheres of pressure, and this was the final result, as you can see. Learning points in this case was that the buddy balloon helped in stabilizing the guide. Serial dilatation followed by rota helped me to deliver the stent. An OP&NC did the trick of final expansion. Using it inside the stent acted like a high-pressure cutting balloon with which we could yield the circumferential calcium. What is dear to me that a string of pearls is sometimes what a woman needs. 68-year-old lady, diabetic, presented with worsening angina, TMT strongly positive, angiogram done 5 years back revealed 100% RCA, CTO, well collateralized, rest was normal. TMT done at that time was negative. Now she had a strongly positive TMT this time, again advised for angiogram. The RCA was similar, 100% occluded, grade 3 collaterals, heterocoronary, circumflex was normal, mid-LAD had a tubular, calcified, eccentric, 80% lesion. What next? Should she go for a bypass surgery or an angioplasty to LAD? CABG was categorically refused by the patient, and on the pretext that the RCA had no new lesion, it was planned to stent the LAD only. The pros and cons of rota ablation was also explained to the patient and attendants. The new lesion in the LAD needs to be tackled, and this must be the culprit for the patient's symptoms. The rota wire crossed. 1.5 burr, 2 passes were done. Now, subsequent to that, the stent passed. A 2.75 into 30 DES was deployed. Now, immediately after that, this is what we see. Now, is this a spasm? Is this a dissection? Or is it a near miss? Anyways, we tried to stent distal to the lesion with a 2.5 into 12. The stent refused to go. So again, we post-dilated at the bend with a 2.5 into 10 OP&NC. This was followed by post-dilatation with 3 into 12 non-compliant balloon. We again tried to negotiate the stent using the guide liner. The stent got dislodged at this point. So we took a 1.5 balloon, tried to pull it out into the guiding after inflating the balloon. The stent got dislodged, tried to pull out the entire assembly. While doing it, the proximal LAD got dissected. You can see the stain there. With serial upgrading the balloon, the dislodged stent was implanted in the mid part of the first stent. Post-dilatation of the dislodged stent was done. After serial dilatation with 2.5 and a 3 OP&NC, we were able to finally deliver the distal stent. Then implanted the fourth stent 3 into 18 to cover the proximal dissection. The fourth stent, proximal LAD, the dislodged stent was deployed, and this was the final result. All 4 pearls were well dilated. So the take home from this case, calcific lesions need all the armamentarium at hand. Before taking a stent distal to a newly implanted stent, first it's best to avoid doing it. But if you have no option, then post-dilate liberally and OP&NC with the device approved for such situations at the moment, as rota cannot be used, and ideal is an off-label indication. Try to take a mother and child guide as far as possible across the deployed stent. We were not able to negotiate the same because of the bad calcific bend. And once the stent is dislodged and partially deployed, as in our case, it is best to deploy at that same spot with serial upgrading the size of the balloon. The 4 stents were deployed as precious as pearls, finally to make the lady smile, and for us to heave a sigh of relief in the cath lab. Ladies and gentlemen, thank you for your attention.
Thank you, madam, for showing excellent cases. We now understand why cases don't come to us from various other places. So, Indore and all, we used to get some referrals to Hyderabad. Nowadays, such extremely tough cases also being done in Indore. Quite appreciable, madam. Congratulations for showing excellent cases. Anomalous RCA, anomalous RCA also.
Toll gate.
Yeah. Anyway, very, very good for the patients locally and very tough cases. Dr. Ravi Bhattina, the expert in CTA angio, commented for your answer, Badri, that the calcium CTA angio is not very good compared to OCT for calcium. He has chatted, he's mentioned in the chat.
Right, I saw that. But they should also improve so that it will be easy for the operator.
I understand. Yes. And we'll proceed further. Any comments on madam's cases for anybody else?
Yeah, after the stent deployment, there is some dissection query. why not some imaging, IVA something to be done to know the characteristic of the lesion? Then you should have directed.
Dr. Badrinarayan, that's a very good question. The only problem is that my center is not imaging equipped. So we do have imaging coming in from time to time, but that is on, it's on a rotational basis. We don't have imaging all the time.
Oh, sorry. But I thought you should have told us imaging. That's why I thought let me tell imaging would be there. That was nice. So much of work would have not been done, right?
In the existing limitations, you're doing a great job. I think Abbott is getting machines also if you want OCT. And,
at the same time, the requirement went to the management, right?
Dr. Sarita, technically very challenging case. You manage it so well. Congratulations on that. And maybe in the near future, we should be having a laser atherectomy also. I'm sure Dr. Srinivas Kumar must be aware of this. I think in the armamentarium for...
Yeah, laser is more user-friendly compared to rotablation, which is slightly more technically demanding. And in non-occlusive cases also, now people are demonstrating usage of laser as the initial modality to make some passage for the balloons to go further. I think that is coming, but the only thing is that is also equally made expensive as IVL balloon. I was hoping at least it will be 1 lakh or something. They also priced it like IVL. So that's a challenge. I think we have Sushil also come back. We will finish another one more lecture before your Sushil. Is it okay? Yeah, I think we will have 2 talks left. I think acute MI, OCT guided PCI, or any other interesting case. OCT Sahu shows interesting cases. PK Sahu from Orissa, please over to you for presentation.
Good evening, Dr. Srinivas and all my colleagues. Is it visible? Are the slides visible?
Yes.
All right.
Sir, please stick to your time for 10 minutes presentation.
I'll finish it before that. I'll try to finish that. Thank you for inviting me. In fact, because it was a case that was selected from 2020, so I had to go through this thing, that is what case I could show. In fact, this is a case where we always use OCT in MI and always think that we have to see something beyond erosion and rupture. Whenever we push a catheter of OCT, we think that is it erosion, is it rupture? That is the 2 things that you see. But there are a lot of things to see, so that is why I picked up this case. Now, whenever there is a culprit plaque, we always try to see in ACS patients whether there is a SCAD, there is a microspasm, there is a Minoka, a Takotsubo, or basically 3 things that you see: a plaque rupture, a plaque erosion, or a calcified plaque. These are 3 things that we need to see. Now, the strategy changes based on these OCT findings. Now, let us take my case. A very young man, smoker, dyslipidemic, has a family history of MI and sudden cardiac death in his father, had an angina, was diagnosed with atrial MI, presented after 6 hours to the first center, then after 2 hours to our center. He was having recurrent angina. The ECG showed atrial MI, had hypokalemia in LAD, rated with an ejection fraction of 50%. In fact, this was on 8th of October that this case had come, and this is this thing ECG, which shows an atrial MI. Now, the RC was absolutely fine. In fact, already had received a dose of heparin, and by the time the dual antiplatelet loaded, and this is what you see in the LAD. Something very interesting to see in the LAD is that almost it looks really normal, literally normal. So the next thing that I thought was that let's just leave this case. We need not do anything in this case, but the patient was having angina off and on. So if you try to analyze the angiographic findings, you try to magnify it, you see that there is some sort of a thrombus over here. This is what we could find on the angio. So then we try to see, and with different views, you can see the thrombus or some dissection, something over here. So what we thought was that it was a spontaneous dissection that had taken place. So this was somewhere in the evening around 1836 that we were doing. So we thought that let's do an OCT. Now, the most interesting thing that you see in the OCT is something very interesting that you see, that is a fibrous plaque you see. But as you come towards the lesion, as you will see that as you go close by to the lesion area, you'll see that first of all, there's a true and false lumen. There's some recanalized thrombus over here. And then you will see a dissection also, and a spontaneous coronary dissection, which is also seen. So all these things, all these findings are quite common in patients with ACS. So what was the diagnosis? Was it SCAD, a recanalized thrombus, or was it a mixture of a SCAD with a recanalized thrombus? So it was all in a setting of AMI. Now, we know that what happens in SCAD is that tunica intima just tears, and as it tears, the thrombus just sets in, and then the full artery gets closed. And this can be well visualized on this thing OCT, and you can see the false and the true lumen, and you can see also intramural hematoma. Let us go ahead to analyze what I saw in my case. First of all, I could see the false lumen and the true lumen at this stage. I could see the recanalized thrombus over here in the true lumen, and here you could see the tight lesion over here in some residual thrombus also in the lesion. And lastly, at this part, you could see there is also some amount of thrombus which is recanalized. So in one set, you could see everything. The false SCAD you could see the recanalized this thing that is lumen. You can see the residual thrombus. Everything was visible. So what do? Do I leave it alone? Number one, or if I see the OCT, there's a tight lesion, there's thrombus which is recanalized, and there is a SCAD. So possibly the best thing would be to intervene, because the patient was having ongoing angina in spite of already the patient being treated with medical therapy. And there was a significant plaque burden, which was fibrotic. And plus there was thrombus along with the SCAD. So if you try to analyze the thrombus again very clearly, first you can see over here that there is a spontaneous coronary dissection, where you can see the lumen, the true lumen, and the other lumen also. In addition, you can see an area where you can see the thrombus. So everything was visible, very much visible over here. So my strategy would be here to use a cutting balloon to make a good pathway, then do the OCT, check the results of on the strands, select the stent size based on the OCT, cover the SCAD and the recanalized thrombus, then do an NC balloon, post-cutting balloon, then stent it, post-dilate it, and do a final OCT run. And that is what I did. First did a cutting balloon, and this was the result post-cutting balloon. And after using the post-cutting balloon, if you see this thing that is OCT, you can clearly see that all the strands have already given away, and there are hardly any strands. And you can see that we have this thing, some of the true and the false lumen have become one. And then if you see the OCT analysis after the cutting balloon, you can clearly see that this is a true and false lumen still remaining to some extent, but all the strands have already given up. And the area has already increased to 3.76 centimeters square. And now then the stenting was done. This was the post-stenting results that you see, that is in different views. You can see after the stent has been put, we can see that there is hardly any shadow is visible. There is no thrombus visible also. So if you try to see the post-stenting OCT, you can see the stent is well expanded. The stent expansion is very good. And of course, if you try to see well along, you can see that there is hardly any area which has not been well opposed, and the thrombus is also well plastered and well expanded. So what we see stenting the OCT analysis, and all the three stages, you can see at the distal part of the stent, no dissection, well expanded stent. In the middle part also, the full part of the false lumen and true lumen have been sealed, and there is no recanalized thrombus over here. And also in the proximal part, the stent is well expanded, and there is nothing area left for any dissection also. And the total luminal area is 6.27 centimeters square, from 1.02 to 6.27. Definitely we have achieved good results. Just so how it looks after the full expansion. Now this is a what we saw, the haziness. All haziness cannot just be a recanalized thrombus. There may be a SCAD, there may be a lumen which is significantly occluded. So an OCT does help in acute MI setting to know what exactly is going on inside. Now, if you try to see the algorithm, then definitely if you have a tentative diagnosis SCAD in ACS, if the patient has refractory chest pain, then definitely you have to consider revascularization, either a PCA or a CABG. But if there is a TIMI3 flow, you can leave it for a conservative management. My patient had a TIMI3 flow, but in fact, he kept on having chest pain. So there was every reason for me to go for a PCI. Or if it is less than TIMI3, In a small vessel, leave it alone. If it is less than 3, TME3, in a large vessel, you consider doing a PCI or a CBG. So one has to be precise. A lack of precision is dangerous and the margin of error is small. So on angiographically, many times you do not know what the error you're going to create. And so try to image it and you will definitely have a good sleep at the night. Thank you very much for the patient hearing.
Thank you, Sao sir, for showing an excellent case and how OCT helps in even decision making in acute MIs. Recently, in the SCAD data, when that what was presented in the meeting, also showed that 70% of the SCAD patients have atherosclerotic basis. That's what findings are seen with OCT and showed one excellent case where cutting and then post-stent apposition. That's how the OCT becomes very popular with physicians. Very crystal clear pictures. And thanks for showing that excellent case. I think other doctors who have logged in the platform are also waiting for Sushil's talk, along with the faculty who logged in this Zoom platform. We'll go to the last lecture. Dr. Anand Ganraj sir, I was surprised when we first invited him for a TCT live demonstration. Chennai Apollo means we generally think a main hospital. There's one more in Vanagaram where he works and does a lot of good work in CTOs. That's why I requested him to show a case of CTO retrograde approach. I think Shao sir, you stopped sharing. And
yes, sir, I've stopped.
Over to you, Dr. Anand, for your presentation. Yeah. And in the final, at the end, we will have Sushil Kodali's talk on bicuspid aortic valve, how TAVR is helping. Yeah, over to you, Anand.
Yeah, thank you. Thank you, Dr. Srinivas, for this wonderful meeting. So basically, my topic is this simple looking CTO PCI. I would like you to introduce you and welcome you to the CTO Center of Excellence, where we have regular training programs and imaging based programs. And our numbers have been steadily going up, and we do about 100 to 120 PCIs a year. Now, the patient is a 65-year-old female, diabetic, hypertensive, and a doctor's mother. Had a inferior wall MI, and I did the primary a month before this. At the time, she had an LAD CTO and a mild LV dysfunction. And this was the angiogram that we repeated during the CTO PCI. Not too great collaterals, but there was one or two visible collaterals. So, but the best part was, if you look at this antegrade angiogram, there was a clear channel coming from the second bulbous portion of LAD at this point. So I really did not plan retrograde. You can see that there's only one guide because I was so sure that we can do it antegrade. Then we started antegrade. This was the second view that I was attempting because the first view I could not really see the starting point. This was, the wire was coiling in the initial bulbous portion. It was really difficult to even get into the second bulbous portion. You can see that even the microcatheter is kind of getting biased. But the wire was exiting LAD somewhere here. So I thought that was some septal or something in the proximal, because you can clearly see that the LAD is coming from here. Then after multiple attempts, I could not really change the wire direction at this point because there was an upward bulge and then a downward course. So I dilated this proximal lesion so that I'll have access to that. Then what happened was I lost even that little bit of lumen that was seen because of the dilatation. And the wire continued to go into the proximal part of that septal branch or whatever that branch was. I was not really sure. But I did not want to proceed with that because I was still convinced that the LAD is here. This was done at a slightly peripheral hospital. So I didn't have IVUS with me. So when you look at LAO caudal, you can clearly see that LAD is here and this wire is somewhere else. So I thought probably this is some ramus-like branch or a very early diagonal which is close to the LAD, and try to rewire that into LAD. But multiple attempts could not get there. So here you can see that The wire has come near the LED from the previous bulbous portion, but you can see that there is some discordance between the LED lumen and the wire. So I believed that it was not in the right space. So this went on for about 1 hour because I was really trying to go antigrade and I had mentally decided not to go retrograde. Then I gave up because there was no way I was going to get into that lumen. So I started retrograde. There were some really nice channels. So after a few attempts, we managed to get the wire up into the LED. This was a Fielder XT, and it went without too much difficulty. Once we reached that point, it was really difficult to get this is a caravel. It was really difficult to get the caravel beyond that mid-septal portion. Though it looked like a very nicely visible collateral, the caravel was just refusing to go. So then I tried to take an injection and see what the problem was. There was no real problem, but the microcatheter still wouldn't go. So I switched to a Corsair. No, this was a stiffer wire. I took a Fielder FC, trying to get a little more support than the Fielder XT. So then finally with that, I was able to push the caravel almost up to the LED. Then after just after doing this, because I was trying to push the microcatheter beyond that point, everything came out and I lost all the access. So then I rewired through another collateral. This time I took a Corsair. You can see that the microcatheter has changed to a Corsair. And again, getting into LED was not really a challenge. So finally, the Corsair was able to reach LED, and the wire was clearly in LED and going into one of those diagonal branches. But the confusion starts again here. You take an injection. Now my wire has come back through the same lumen that I was in antigrade. But angiographically, it looks like LED is proximal to where I was. So I did not feel confident to really push the microcatheter. So I tried manipulating the wire. Though the wire is now facing away from left main. So a lot of confusion, angiographic confusion. Then finally, I managed to bring the wire where anatomically the LED looked, because previously the wire was somewhere in this branch, which didn't look like LED. But if you see this, if you come from that branch is not leading to left main. Again, the wire has gone off from LED and the wire is somewhere outside left main. Look at this wire loop. The wire was clearly outside left main. Till today, I don't have an idea where it was. But now it looked like we are through the actual LED lumen, but the wire is not entering into left main. It is coiling around somewhere here. It looks extravascular actually at one point. So this confusion was just, was not sortable in my mind. Then again, I rewired and look at this position. Now again, the proximal part of the wire looks like it is come through LED, but little bit off LED, but clearly outside left main. So I was not sure whether I am in the subintimal space of left main or extravascular at that point. Then I pulled out all the wires and came back with Fielder FC this time, trying to use the hydrophilic part of it to negotiate the whatever confusion was there without really, this is not done on purpose. I'm still trying to go through whatever lumen I had. At this point, strangely, the wire somehow looked like it had reached into left main and I was able to get into the retrograde guide. And this, till today, I have no idea what was the previous thing and what this was. And once I got into that, I was able to get the Corsair into the antigrade guide and push this wire up. We had to do remote rendezvous somewhere here. You can see that because the patient was actually crashing because I had manipulated so much in the left main. There was no thrombus, there was no dissection, but the patient was quite unstable. So I did not have time to externalize the wire and take it. So I just took the caravel that I had taken out and threaded it at this point into the retrograde wire. And then I had now this antigrade caravel and retrograde Corsair all connected through and through. Here, this is one danger that I would like to specify about what is called the Chinese case, where if you really don't watch it, these two microcatheters can actually get jammed into each other. And sometimes they become very difficult to remove from each other. So you have to maintain a healthy distance between the two guide microcatheters as you go back. So the caravel went into the septal without much difficulty. So I tracked the antigrade wire with the fielder and came down into the septal as far as I could and pulled back the retrograde wire. And now at this point, I clearly had access to LAD, wired down, had the microcatheter, and lost it. Okay, because the patient was unstable, patient moved and got up and coughed and vomited, everything is out. But this time, there was one thing I knew, that this was the lumen through which LAD is there. The first lumen that I thought was the wrong lumen was actually the correct lumen. So this time I just wired antigrade through the same loop and it went just in 5 minutes. And this is what I should have done in the beginning, but I did not realize that there was this loop was a very tricky loop that I could not understand when I started the case. So finally, again, even here, when you look at it, your stent is in that track, and the LAD that I thought was somewhere here, and actually the entire thing is LAD, and that was a micro channel. And finally, we stented it, and the procedure, it all ended with a one simple stent, and then patient became stable. So the learning points, first of all, we sometimes consciously or subconsciously underestimate the lesion. I just look at it and sometimes I say, okay, let's go. I think that always a healthy respect for CTO is absolutely necessary. And a clear visualization of the lesion is important. When you assume that this is what it is, leads to a lot of problems. And actually, I was unprepared for a complex CTO case. I thought this was like 15 minutes case. So I had not taken a double puncture. I had not prepared. I had not informed anybody. I had not spoken in detail about the complications of the retrograde, nothing. I was so sure it's going to be antigrade and was mentally and otherwise unprepared. And imaging would have really helped at this point, but unfortunately we didn't have it in that hospital. And this is a very kind of, not a very good point to say, but sometimes you have to proceed in spite of this confusion, because there is no other option available. Either you abandon the case or you just continue and somehow finish the case. Thank you.
Thank you, Anand, for showing an excellent case, and persistence is the key. I think imaging, if you have seen that antigrade works like what you thought before, would have helped. I think Dr. Sushil has to go again. He is on call. We'll have his talk. A lot of you must have been having questions, but excuse me. We'll have Dr. Sushil Kodali's talk and then we can have some discussion in the end.
Thank you.
Over to Sushil. Can you share your screen? Hello? Is he there or is he left?
Hey, so I'll be right there. Sorry, just trying to get the slides up.
Okay, no problem. We can have 1 minute discussion, then you trying to get the slides. Sarita madam, you were wanting to say something?
Dr. Anand, very nice case and very beautifully completed. I wanted to ask you, did you think of using anterogradely microcatheter? Anterogradely, did you want to use Corsair in the beginning, or did you want to use a dual lumen because you had a branch coming out from there?
Yeah, I didn't use a dual lumen. I could have used a dual lumen because there was a tight lesion just before that where I thought the lady branch was. So the dual lumen was not going through that. So I kept trying with the microcatheter. But then the moment I dilated that lesion, I lost visualization of whatever I thought was the LED. So I had to abandon that path because it was no longer visible. So that is why I had to switch to retrograde, because the dual lumen would not go through that space. And dilating it with a 2 millimeter balloon was kind of a mistake.
Anand, can you stop sharing of yours so that Sushil will start sharing?
I thought I stopped sharing.
Okay, right. Madam,
So
you're trying to...
whenever we go retrograde,
pardon?
So whenever we go retrograde, and many times when I've seen that when my fine cross or whatever I'm using at that time doesn't go, it always helps to switch to a new one, a New York one, and that usually goes through.
Yeah, 99% I use only New York stuff, so mostly I don't have that problem. But sometimes switching from Corsair to Caravelle helps, and sometimes switching from Caravelle to Corsair helps because of the hydrophilic coating. So there are some microdynamic factors that help. So cost-wise, it looks really difficult to switch from one microcatheter to the other because each one is 50,000 rupees. But end of the day, you have to succeed. So we do it.
Dr. Anand, is a great case. I'm Dr. Barua. Which one you feel better, caramel or this out of this microcatheter? Which is you feel that?
Personally, I am a great fan of Corsair.
Corsair.
But because of the cost, I try to use Caravelle as much as possible for retrogrades because it is finer, it is smaller, and if there is a good collateral, it goes through without difficulty. But the moment you find a little bit of a difficult course, then Corsair is a much better microcatheter. And retrograde wise, it is only the channel size. Especially when you come from LAD to RCA, somewhere in the lower third of the septum, these microcatheters have difficulty in crossing because there are some small bends, and I think there is some capillaries little diversify in this point. That in those areas, the Corsair is much better. You can actually drill it through, whereas Caravelle has only a pushing force. You cannot really screw it through.
Yes.
So, yeah.
And Corsair is very reusable also. So I reuse a lot of stuff, and Corsair gives me very good results on reusing also.
Okay.
Yeah. But you lose the hydrophilic coating after the first time.
Okay.
So you.
But still you can reuse.
Yeah. You can reuse. The purpose of a microcatheter is to give focused torque to your wire, so that you can use it multiple times. The challenge comes only when you have to cross a tough lesion. There you want the slippery coat.
Yes.
So you can always use a O catheter, and if you are unable to cross, switch over to a new catheter.
New catheter.
Yeah.
Yes. Great case. Yeah.
Thank you.
Yeah. I think if Dr. Kodale is ready, then we can go ahead and we can come back to the discussion later.
Dr. Godali suddenly is on call. He got a call for primary PCI. He's just sorting it out and he'll come back. That's what he mentioned. Even that super tower expert in the world also gets a call, takes a call for primary PCI. That he actually was passionate about it. He wants to take it.
Hi, sorry, Shiraz.
Yeah, please. If you have to leave, then briefly you can comment and go. If you have time, you can give your
No,
lecture.
I think it's okay. No, I think I'm okay. Can you see my slides?
Yes.
Yeah, we can see. Make it full screen. Yeah, perfect.
Yep. So yeah, I apologize for. Unfortunately, I'm on a call today, so I was just sort of answering one of those questions. The the real issue, and those are fascinating talks. I learned a lot about the coronaries, and I know that a lot of the structural cases were done yesterday. And I apologize I couldn't join yesterday, but Srinivas asked me to give one lecture and about TAVR and sort of some of the issues. And one of the things I thought I'd discuss is bicuspid valves, because I think it's more of a topic and relevant topic in India, and you see a larger percentage. And as TAVR is growing, I think it's one of the more complicated issues. I'm sorry, I really apologize. Can you hold on 1 second? I apologize. Sorry.
We keep seeing a lot of young patients also being taken up for TAVR in the country. That's how I think we always have a bias and mindset what to decide and which type of patient. In US, what I was told is they are always particular that they won't take up any patient less than 70 generally, maximum up to 65. Go ahead.
Okay. It's not a STEMI, so I'm okay now. Sorry about that. The issue of bicuspid valves, and we've discussed it, and I think, part of the challenge is we don't have a lot of data about TAVR and bicuspid valves, but we also, bicuspid valve is not a single entity. When we're talking about bicuspid valves, we use the term generically, but the reality is there's a lot of heterogeneity in how it presents. And so, I think it's important to really understand the anatomy. And I think over time, we're going to need to get more data. And there's obviously different classifications. And this is the historical classification. We called it type 0 without a raphe, type 1, which has, a single raphe, and type 2 with 2 fused raphes. And with age and with region, the presentation of each of these can change. And so part of the challenge is the TAVR devices are really designed to treat a circular annulus. And bicuspid valves, by their nature, are not circular, they're asymmetric. And I think that becomes one of the challenges. And that can lead to variability in outcomes, not only in acute results in terms of PVL, annular rupture risk, and other factors, but also in terms of long-term results in terms of durability. When valves are asymmetric, they tend to not last as long because the stresses on the leaflets are more abnormal. So when you have a bicuspid valve, you might get an asymmetric deployment and have abnormal leaflet function and early failure. So I think there's a lot of different concerns, and the primary, as I said, is the asymmetric nature of the annulus. When you put a TAVR, the tricuspid valve, you get symmetric expansion, and ideally into all of these commissures. With the bicuspid, you may not get sealing at the commissures, and you can get paravalvular regurgitation and lead to PVL. The heavily calcified raphe, which is common what we see in sort of these type 1 bicuspids, plays an important role as well. And part of the issue is when you do a TAVR and you have this calcified raphe, if it doesn't allow the valve to expand in this direction, you get asymmetric deployment of the valve, and that can cause root injury on this side because you don't have room for the valve to expand. But it can also lead to non-circular deployment. If you have a calcified raphe here, heavy calcium here, you may get an elliptical deployment. This is an example of a sapien valve. You see here, this is one we did a long time ago. But we have a calcified raphe, and you see the valve is a little bit oval. And especially intraannular valves, if you're oval, this leaflet is not functioning because it's not stretching normally. And then there's obviously concomitant pathology with bicuspid valves with aortopathies, and you have to really understand whether those valves, if the aorta needs to be done, that patient should probably have surgery. As I said, there's not a lot of data, but recently this was a large data set from the US from our national registry called the Transcatheter Valve Therapeutics Registry, or TVT registry. Every case done in the US has to be entered into the registry. And that's part of one of the conditions for reimbursement by our Medicare, which is a national payer. So by definition, they will have the vast majority, 99% of all cases done in the US. And so they took, at this point, this was up to 2018. There were over 90,000 SAPIEN 3 cases in the registry and about 2,700 bicuspid. they matched these bicuspid patients to a similar group of tricuspid with propensity matching, and there are these covariates that were used. And what you saw in general was, overall, the results were good. Device success was high, 96% in both, no difference. Conversion to open surgery was a little bit higher in bicuspid. The annular rupture rate was low, but it was definitely higher in bicuspids. It was 0.3%. And the need for a second valve was a little bit higher in bicuspids. But overall, the results were still pretty good. Now, you look at the other key outcomes, mortality was no different. Strokes were a little bit higher. These are all site reported, but 2.4 versus 1.6. Pacemaker rates were a little bit higher, 9.1 versus 7.5. And these are all important considerations. And when you looked at the 1-year mortality between bicuspid and tricuspid patients, there was no difference at 1 year. Stroke rates were no different at 1 year either. And paravalvular leak, which is one of the important considerations, was not very high. I mean, again, site reported, but the rates of moderate or greater PVL were around 2% or less at 30 days, and no difference between the two groups. And so the vast majority had none trace at 75% roughly. So those were all encouraging results as well. And then hemodynamics, essentially no difference, overlapping one over the other, with the mean gradients of around 10 at 30-day and 1-year follow-up, and valve areas around 1.7. No significant difference between bicuspid and tricuspid. But these analyses have a lot of limitations. There's selection bias. The bicuspid valves that were treated were the ones where the operators felt they could do a good job with TAVR. So it doesn't necessarily include all of the bicuspid valves. And we don't know the patient risk status. We don't know aortopathy status. And then in terms of the results, these are all site reported. There's no core lab. So for instance, PVL especially, we know that physicians in general, when you look at a core lab versus site reported, we're going to underreport our PVL. And there's no CEC to adjudicate outcomes. But it's still a large data set showing that it can be treated. But, I think, one of the important things, this is all still relevant early data with early generation devices. And I think we need to get a better understanding of what bicuspid means for TAVR. The CVRS classification is not the same. It doesn't help us categorize which ones will do well. And I think that's where, there's people have proposed new classification systems, either tricommissural with 3 commissures, or bicommissural without a raphe. I mean, this is essentially the type 0, but this is sort of a spectrum. This is bicommissural with a raphe, calcified raphe. This is the vast majority of patients. And we need to understand how TAVR interacts with these different valve phenotypes, because it's going to be different. The valve will expand differently in this anatomy versus this. I think those are all important considerations. And it's important to understand what is the impact of calcium and heavy calcium. And so this anatomy doesn't have a lot of calcium. There's a lot of fusion, excuse me, a lot of fusion, but not a lot of calcium. Whereas here, you have a lot more calcium. Excuse me. And so the goal with all of these TAVR devices is preventing PVL. And normally with TAVR, when we're talking about PVL, we're talking about sealing at the annulus. You got to seal the valve against the annulus. And we have a chunk of calcium in the LVOT that can affect sealing. But at bicuspid valves, the seal zone may be moved up, and that calcium may not matter, because in a valve like this, the sealing can occur at the leaflets at a much higher level than at the annulus. And basically, to prevent PVL, the skirt of the TAVR device has to cover the seal zone. And in bicuspid valves, the seal zone may be higher, and the valve needs to be deployed higher. And so you got to look at each anatomy and say, where is it going to seal, and what is the size at the level that it's going to seal? Is it at the annulus, or is it higher up at the leaflets? And in a lot of this stuff, this question of this raphe, it doesn't crack, but that was always the concern. What happens if you try and seal up here and then this opens up, then you're going to get leak around it. The reality is these are fused, calcified, and they don't crack. I just want to give you some examples. This is a bicuspid valve with probably a raphe here between the left and right, minimal calcium, and you can see that raphe here, and this would be calcified as a tricommissural with raphe. So in bicuspid valves, I tend to look at the BAV. I generally balloon all of the bicuspid valves because I can see the behavior of the leaflets. I can see the behavior of the balloon. Is it opening easily? Is it opening to one side? What are the concerns? And so in this particular patient, this was an older patient, older trial, Sapien XT, but there was good circumferential expansion of the valve and minimal paravalvular leak and no issues. So this is an anatomy where it's really bicuspid, but these anatomies are ideal for TAVR, and you'll get results comparable to a tricuspid. But there are ones where you may not. And again, I worry a lot when you have this heavy calcium, especially a calcified raphe. And this is a core valve, and you can see at that level of that calcium, the valve is asymmetric. Now with core valve, that's okay. You have supraannular leaflets, and you may still get normal leaflet function, but it can lead to other complications, as I'll show you here. And this is an example of a core valve we did. This was a type 0. And you see here we want to deploy high. And what happens here with bicuspid valves is you can get long leaflets. And the leaflets are long. And if your core valve ends up low, you can get leak through the stent frame. And here at the level of the leaflets, we're very asymmetric. And you see the leaflets opening, but this will impact leaflet durability in my mind. And if you're low, you essentially here, we ended up almost intraannular, so to speak, at the level of leaflet coaptation. And that's why you're getting these asymmetric leaflet opening. And I think that can really impact durability. So we did not, even though there wasn't a lot of leak, we didn't like that. And we decided to post-dilate. And you see with post-dilatation, although it's not perfect, we get much better expansion and more circular. And the mean gradient went from 13 to 5. And so I raise this as an example of, especially in bicuspids, I tend to use TE because I like to understand what my result is. And you need to do a careful interrogation of the valve after deployment. And if I had gone RAO, I would have seen that valve was underdeployed. And even though there's not leak, the post-dilatation was for better valve expansion. And the mean gradient was 13 to start, not bad, but with post-dilatation, it was 5. So I think you need to do more careful sort of post-deployment assessment of these valves to understand what best to do. And this is an example of extreme. This is presented by Dr. Testa at a GYM meeting in 2019. And this is an example of a heavily calcified valve, calcified left leaflet, non and right fusion with a calcified raphe. And you look at this accurate valve, in one view, you see it expanded, but in the other view, it's not, because it just never opened, doesn't have the radial strength to open. So there are some questions about valve choice and in some of these anatomies, and I think you have to be careful that you don't end up in a scenario like this where now you're stuck and it's going to be really impossible to post-dilate this valve, and this valve may not have the radial strength. So there are certain anatomies that you have to be very cautious of. And this calcified raphe can also cause injury, because when you have a raphe like this, the entire valve is going to deploy over here. It's not going to deploy in the center of the sinus. And when everything gets pushed over here, you can get a contralateral injury. And I think in high-risk anatomies, we look at the root on TE as we deploy. And you see here, this was not a great example. I pulled the wrong slide. But here you'll see it at the end briefly penetrate into the root. And that can be useful. And there are also other unusual risks. And this is a valve with again, non-right fusion, non-calcified raphe, a small left coronary leaflet. The heights to the left main were a little bit low, but not terrible, 11 to 12. But the sinuses were big. They were 34. We chose to do a BAV sizing. This is a 26 millimeter balloon, which we thought we had a waist and a good seal, especially on TE. So we elected to go with a 26 millimeter Sapien valve with sort of a normal position. And you see we end up about 1 or 2 below the annulus here. You see a nice waist here. But immediately after deployment, refractory hypotension, the LV function dropped, patient went into VF, and we had to shock the patient. And you see here again, there's no flow in the left coronary now. And so we've included the left coronary despite a sinus of 34. And you see here, when we inject, the native leaflet is sealing the sinus. We've push the native leaflet up. This white line is the native leaflet, and we've sealed off this sinus and obstructed flow. We get some flow around it when we inject with the catheter, but we've essentially sealed, and that's why the patient arrested. We had to put the patient on ECMO. We wired around that frame, got a stent, and brought that stent back to the STJ and to stent that leaflet open. And the patient recovered and went home. But if you look at what happened in this scenario, normally we'd expect a 26 millimeter S3 to sit like this, and there'd be plenty of room to the left coronary. But because of that calcified raphe, that S3 did not sit there. It got pushed towards the left. It wasn't sitting central. It was sitting over here. And you can see that on deployment. And by doing so, we sealed off the entire left coronary sinus. And so you can imagine here, you know, this sort of left sinus is shorter there, and this is, it's very asymmetric. So this leaflet sealed off this sinus, and that's why we occluded flow. And I think those are important lessons, and you may need to look at that. And so when you're doing, you know, transcatheter valve replacement in a bicuspid valve, there's a lot of things that you need to consider. It's not just annular size. It's whether, what is it? Is it a bicommissural or tricommissural? Is there a calcified raphe? Those are all important considerations. And eventually those will be important considerations as we know more about which valve type we choose, whether it's a sapien or a core valve. You know, in the past we used to use Lotus, and Lotus worked really well. And so, you know, I think these are all important considerations. So, and you need to look at root size, is there room? And these are all factors that go into the choice. And it's you know, bicuspids can be done, but there needs to be a lot more caution. You need to understand how the valve's going to interact with the TAVR device. So I'll stop there. Thanks a lot.
Thank you, Sushil, for an excellent talk with guidelines to deal how the complex anatomy in bicuspid patients. As you do more and more cases like you, and then I think you go into more and more intricacies and learn a lot with asymmetric expansions. I remember when we were doing cases together, the calcium chunk on the other side, the companies predicted little higher sized valve because of Sushil's expertise. We put it on one size less. That's how it was almost about to rupture, but still stopped. That helps a lot, proper analysis of the CT. And he guided us and made us learn the CT angio, the 3-Mensure software. All of us need to become comfortable with 3-Mensure software usage. And there are some indigenous softwares also available now, like EndoViz and other things. And one thing on this, for this iPad users also, Mac users also, there is one other software available freely for us to practice. I think one thing which bothers us is about the age group of this patient, Sushil. What age you are comfortable? What is the lowest age group which you've done in US?
You know, this is all sort of changing. I mean, I think, you know, it's about durability, and there's culturally different issues, and, you know, it's about being open and honest with the patient. You know, if I see it in the U.S., average survival is, I mean, it's changing in the COVID era, which is sort of sad, but average survival, I would say, is 80. And so if someone is getting a TAVR at 60, I tell them there's a reasonable chance that, you know, they're going to need surgery in their lifetime. And it changes depending on, if I have a small person, I can put a 29 millimeter Sapien 3. I know I can comfortably do a valve and valve. But if I have a small person with if I have a small annulus, small sinuses, I'm not going to be able to do valve and valve. So that 60-year-old or 65-year-old even is likely going to need surgery. And you can have the conversation with the patient and say, this is the concerns. And if they understand that and they're willing to undertake that risk, that's okay. But I think there has to be a conversation about the unknowns. You know, about durability and the potential impact of that on sort of valve choice and surgery versus TAVR. But I do people in their 60s, but I have a conversation with them.
Yeah, we took your guidelines and I presented, when you're not there, the TAVI registry, what we made in Apollo for the data to be entered. I have mailed you and sent you in WhatsApp. Please, you can see and advise us if any other parameter is missing. So we would add up in for the registry. As we discussed, we are trying to network and make all the TAVIs done in Apollo units to be in one registry and try to come out with some data which is reasonable. I think thank you for all the help and guidance. And any other questions before we close, sir? Dr. Saurabh Banerjee, sir, is very senior expert cardiologist from Kolkata. And many of the very quite interested even at this time is still there. Do you would like to ask anything or?
No, I think it was an excellent presentation, and there was quite a few things we learned. And I would really congratulate Dr. Kadali for taking his time out in spite of a busy schedule and being on call tonight.
Yeah, sorry about that. No, I apologize. You always try to time it. I thought it would be fine, and it never is. So that's my mistake.
No, that shows you give us so much importance in spite of anybody else would have just canceled the talk and not joined. Thank you very much for your association and great help. And I should say that whatever TAVI cases which you did in Apollo, main Jubilee Hills is all because of his guidance and expertise. Actually, whatever recently certified us that you are now an independent operator. Once we did one difficult bicuspid valve recently. The latest cath lab. Thank you, Sushil. And if there are no further questions, anybody who has any questions to Sushil, you can feel free. Otherwise,
yes, please.
So I would like a wonderful talk. Congratulations to you. 2-3 things I wanted to ask. One is that when you're doing bicuspid, do you prefer a self-expanding over balloon expandable? One question. Second is, do you like to post-dilate these patients? And the third thing is that at what position do you like to start deploying? Because, even when we started deploying at 4, it jumped back to 0 position. So these 3 things I would like to know from you.
Sure, absolutely. I don't think there's a great answer about, balloon expandable versus self-expanding. I used to like Lotus when it was around. And now it really depends on the anatomy. If it's not a calcified raphe and it's relatively symmetric, I tend to favor balloon expandable, especially if it's a large annulus. But in many of these ones with really calcified raphe and sort of smaller sort of openings, I've been using self-expanding more, but I always pre-dilate. I think the challenge of using a self-expanding in these anatomies is you deploy the valve and it's pancaked. And I think when you deploy valves with these bicuspid valves, it's important to go to the orthogonal view. So, I don't know if your preference is to deploy an LAO, a lot of people do, but it's important to go to that RAO view, because in the RAO view, in the LAO, the valve will look like this, big, but if you go in the RAO view, it looks it's pancaked. And that means that you're not opening. And so if you see that pancaked appearance, I would not deploy the valve. I would recapture, come out, and if you did a balloon, then do a larger balloon, because when that happens and it's pancake like that, several things happen. One, the nose cone might be stuck and you can't get the nose cone out after you deploy the valve, and then 2, ballooning it after, you risk popping out the valve if you do that. So I think for those scenarios, I would be very cautious with self-expanding and really adequately dilate the valve before. Even with balloon expandable valves, I tend to dilate them first because I think in bicuspid valves, unless the angle of the aorta is very vertical. But if the angle of the aorta is horizontal, crossing these can be difficult even with the flex cath. So I will tend to balloon them first, but there's no right choice about which is better or worse. I think you have to just look at each individual anatomy and try and understand, is the valve going to sit and sit appropriately in that valve? The balloon expandable valves have more radial strength, but there are anatomies where with a lot of calcium, there's not room and you risk annular injury. And I think that's the big thing with balloon expandable valves, especially if you have that calcified raphe and the whole valve is going to sit to one side. That's when you get annular injury. And in general, the last question you asked was about positioning. Whether it's self-expanding or balloon expandable, I try to position high. I think one of the things that you had to be cautious, and this was the case Srinivas was just talking about when we were looking at the case that they did. If you size, if you have a bicuspid valve, a lot of people, we try to implant really high and you try to seal at the leaflet tips. Because as you can imagine, if you have a bicuspid valve, if the skirt is at the leaflet tips, you'll get sealing there. And so some people have advocated sizing based on that. And in that case, if you size based on that, it would be a 26. But if you sized on the annulus, it's a 29. The challenge with putting that 26 that high is you have that shoulder, and these leaflets are very restricted. And so, you have the shoulder of this core valve here. And if the leaflets sort of hit there, what they end up doing is they end up pushing the valve a little bit low. And then you get leak through this, because the skirt is only 12 millimeters high or so. So you get leak through the stent frame. And you're not going to seal at the annulus because it's not sized appropriately to the annulus. So in that case, he decided to go with a 29, balloon it 29, seal at the annulus, and got a good result. So there's not a right answer. And I think we need more data, and there is more data that's going to come. But the problem is it's not one entity, and it's trying to understand in the particular anatomy how the valve will sit. In general, though, I would prefer to deploy higher than I would with a tricuspid.
Thank
I'm not
you,
sure if that
Sushil.
answered the question. I answered the question by saying I don't know. So I'm not sure if it really answered it, but it's a lot of considerations.
Thank you, Sushil. Dr. Ravi Bhattan sir is also watching from US. Do you have any final comments? You want to say anything, sir? I think if there's nothing, 9:30. Sir, thank you. Thank you for always encouraging being part of it. At his age, and he still always encourages all of us. Thank you. You are muted, sir. If you want to say anything, you unmute.
No,
Yeah.
Thank you, Srinivas. Wonderful. Sushil, I want to tell you something. You look much younger now than before. What's your secret?
No, I don't think so.
Wonderful.
Thank you.
Take care.
Take care.
Thank you, Sushil. I think it's 9:30 plus now. Thanks for everybody for all the cooperation and interest. That's what gives us a lot of enthusiasm and to do all such programs. And thank you all the colleagues across Apollo, and thank you all the cardiologists for outside Apollo also for watching in the live streaming platform. And I should be always thankful to Sushil, Ajay for the unending cooperation and collaboration. And whatever programs we do, whatever even we tell in the last moment, also they try to adjust and help us like this. Thank you, Sushil.
Take care. Good luck and stay safe, everyone. Be well. Take care.
Ramesh also was there yesterday. And in the last time, what I would like to mention in the live cases were tremendous. Actually, first case there was some trouble, Sushil, but second case which came from a second set of cases which came from Kolkata and Mumbai were very well received without any interruption. One was how to avoid left main ostium and LED diagonal bifurcation was shown. Other was again left main crossover stenting was shown with good OCT pictures. And we had good case presentations from various other centers of Apollo also. And that's how all of us learned a lot, I feel. And thanks for all the cooperation. The last, what I would say is live cases are all good, but they all come with some cost involved. So when I discussed this program with the various companies, and Abbott, which is the leader, again came forward, readily agreed to do whatever support is required without any conditions of whatsoever nature. So I thank all the Abbott people, Subodh, Ravikiran, and Anil especially, who have been always constantly working. And even now, they don't need to, but they're still there in the back end and working and seeing that everything goes well. I did tell this to Medtronic, Edwards, and others too. And Medtronic generally helps, but in the recent state conference, they had done something. That's why they couldn't participate in this. And anyway, we are a Zoom platform. We didn't need much. And without Abbott's cooperation, this meeting would not have been possible. Edwards also is trying to come up with some participations. And that's how the live case transmission, which came from Chennai, was supposed to be done but through them. But Merrill Maival also is doing good number of cases in India. And thank you all for this wonderful cooperation. And I hope Abbott people have listened to what I said. Thank you all for your cooperation. And thanks Apollo Management, Sangeeta Madam and Hariprasad sir, and Tamarish Kole, who were joined as a group team coordinator, was networked across all the hospitals. And our back relations with the TCT conference experience, we are helping, knowing all the cardiology colleagues across the hospital helped a lot. But with this, I also made some new friends with whom we are not knowing. That's how I think not only academics, this also comes a lot for helping and networking with colleagues. I see women empowerment is also happening a lot in cardiology. A lot of lady colleagues participated. And Sarita Rao madam also did one tower there in Indore. That's why she's asking questions. It's all good. And with this, I'll conclude. And thank you all. And have a great weekend. Thank you.
Thank you.